Good morning, everyone. Thank you for being here today. My name is Andy Mays, and I am the Commissioner of the Connecticut Insurance Department. We're here on an important mission. We're here because we know that healthcare costs are rising, and we need to figure out the levers to address those costs. So I want to thank everybody who's here, everybody who was watching on CTN. And I want to thank all the participants for being here, because this certainly was not the easiest thing to do. We all have to sit together and look at the various drivers, look at the part that we each play in healthcare and healthcare costs, and try to figure out what best we can do for consumers. Now, on this side of the table, I am pleased to have some of the most outstanding members of the administration. I'm going to start on my immediate left with the healthcare advocate, Ted Doolittle. And for those, Ted will go into his background in more detail shortly. But Ted is, for those who don't know, an independent healthcare advocate representing the people of the state of Connecticut. He's got, his only concern is what's best for the people. On my far left is Kim Martone. Kim is the acting director of the Office of Health Strategy, and the Office of Health Strategy has been charged with, among other things, looking at costs and trying to figure out what we do to restrain cost growth. Also joining us on my right from the Connecticut Insurance Department is Paul Lombardo, who is my Assistant Deputy Commissioner for Life and Health in the department. Now, we have many experts here today to help us better understand their role and their perspective on controlling healthcare costs for consumers. The purpose of today's forum, and in this really warm room, because I'm getting hot here, but the purpose is to gather information and to have a dialogue with the panelists. It is not about blame. It is about sharing information. It is about asking questions. And it is about learning from each other as we proceed. We have three panels with us here today, and they will be presenting information on the main drivers of healthcare costs in the US and in Connecticut, how medical prices are determined, and other factors in setting pricing, with an emphasis on hospitals and pharmaceuticals. There will be a follow-up meeting to be scheduled to discuss next steps, and we will plan on the best approach to address the rising costs of healthcare, and Ted Doolittle will have some more to say about that shortly. I'd like to move to some housekeeping items. Due to the amount of material, this is a long hearing, the amount of material being presented here today, we are going to try to hold our presenters to their allotted time. And if all goes well, we should be able to wrap up around 3 p.m. or so, which means you will have some time for dinner. Thank you for being here today. And to begin this most important hearing, please let me turn it over to the acting director of the Office of Health Strategies, Kim Martone. Kim?
Thank you, Commissioner. Good morning for joining us today for the Healthcare Cost Drivers informational session. I'm joined by my colleagues from the Connecticut Insurance Department and the Office of Healthcare Advocate, who both share the same reason why we are here today, to get everyone on the same page on what is driving healthcare costs, and not only for our state, but around the country. Healthcare costs have been growing at an unsustainable rate, leading to challenges in affordability of care, rendering health services and health insurance premiums unaffordable for our residents and employers. Today, we'll hear from local and national speakers, including hospitals, non-hospital healthcare providers, pharmacies, insurers, and academics, who will provide their expertise and insight and put Connecticut's healthcare affordability challenges into national context. The Office of Health Strategy considers healthcare affordability critical for the health and outcomes of Connecticut residents and to the longevity and effectiveness of Connecticut's healthcare system. We began work in 2019 with Governor Lamont to make healthcare spending more transparent with an eye toward identifying strategies to address barriers to affordability and bending the cost curve. The Healthcare Cost Growth Benchmark Initiative is a necessary reining by bringing about an unprecedented level of transparency and oversight across all stakeholders, holding organizations accountable for excessive growth and to incentivize redesign of healthcare delivery and payment models in this state. For over 3 years, the Office of Health Strategy has been working diligently to fulfill these goals and seeking input on implementation of the initiative, which includes standing up various stakeholder advisory bodies, engaging patients and consumers, providers, insurers, employers, and state partners, which are some are here today, to address this very issue affecting everybody in the state, the continually rising healthcare costs in Connecticut, amongst the highest in the country, growing at a rate much faster than personal income, causing our residents to delay or forego care, and inhibiting business investments. Today, OHS has published the first cost with benchmark for 2021 to 2025. Beginning from August 15th, 2022, and yearly thereafter, both private and public payers are required to report requested information to OHS for performance comparison against the benchmarks. Until the governor issued his executive order, Connecticut did not routinely report on overall healthcare spending across the state by private providers, Medicaid, Medicare, or on resources devoted to primary care. We cannot improve what we don't measure, so transparency is absolutely critical. We know healthcare is unaffordable in our state, which is why we are all at the table today, to better understand what is driving these costs and how we can help limit the growth so that we can help residents better afford a high quality of life in Connecticut and encourage business investment. Today's discussion will set the stage for developing solutions that will build upon that work with the Connecticut Insurance Department, Office of Healthcare Advocate, and OHS. And we will do this together to make care affordable. Thank you.
Thank you, Kim, and thank you, Commissioner Mays. I appreciate the work of the Insurance Department as well as the Office of Health Strategy in pulling this together, and certainly the work of the staff here, Alex Pachowski and Jim Carson, Paul Lombardo, Jared Koski, Olga Arma, Sumit Saznani, and Adam Prizio are to be thanked for their work in this, and I appreciate it. And I appreciate the panelists here on panel one, as well as the next couple of panels afterwards for taking the time to be here and share with our community as we grapple with this healthcare spending problem, which I think it's not unfair to call it a crisis or a near crisis. The costs of medical care in the United States are internationally abnormal compared to the other high quality and wealthy nations. Healthcare is a human right. I really believe that strongly, but I always go back as I'm thinking about healthcare to a quote by Warren Buffett, who said that medical costs are the tapeworm of American economic competitiveness. Medical costs are the tapeworm of American economic competitiveness. So this is not only a problem for our families and our loved ones, but it's also a problem for us as a nation competing against other countries, and us as a state competing against other states. So that's why it's so important to have this discussion. The idea here is to have a frank discussion, to gather facts, to describe the landscape as industry experts and outside academic experts see it. We'll drill down on the solutions later, as Kim and Andy said. But today it's time for you as industry experts and as academic independent experts to try to get some of the facts out on why we think we are where we are. We didn't get here overnight. It's been 40 years coming to where we are. So to folks in industry, I just want to know, you to know that we want to know your pain points, right? You're closer to the work, right? You know the work best, and you are, in addition to working for your own organizations, you're good citizens and community members. And I know that you think about this on a frequent basis. And we're looking for suggestions from you. What are the exit ramps? What are the solutions? And we'll talk about that later. I'm looking forward to a respectful and honest discussion. But also, we can't shy away from the data, which sometimes is not pretty. And you're going to see some data that is, frankly, doesn't reflect so well on the United States. One other word for industry, I will say, as a state official, that the regulators, the policymakers, elected officials, and others, we in the state need to be humble and understand that you're closer to the work. And I have a very strong sense of that. I worked in an insurance company for several years, enough to understand it's way more complicated than I can comprehend. So we're looking to you guys for guidance and suggestions and partnership. At the same time, industry does need to understand that the regulators and the policymakers are closer to the people and the community in certain ways. We're accountable in ways. There's a couple of elected officials at the table. They're directly accountable on a daily basis. And to my folks in industry, I would just simply humbly say, understand and appreciate that we see an important view and represent an important view, and we want to have a partnership with you. I'm looking forward to the first panel, which I believe Commissioner Mays is going to moderate with Kim and myself. And as I mentioned, I'm looking forward to a solutions-oriented session later on. I will say, I've mentioned to the panelists, and I'll repeat again, your testimony time, your time to talk and discuss will be limited, but the website is unlimited. So if you have any additional materials you want to go on, and OHA, my office, the Office of the Healthcare Advocate, will be putting on some materials as well to help guide industry leaders and state leaders. So thanks very much for being here today. Much appreciated. And I look forward to trying to work on this problem together as a community. Going to turn it back over to Commissioner Mays. Thank you, sir.
Thank you, Ted, and thank you, Kim, for so clearly framing what is before us today. And I do want to echo what Ted and Kim said, and thanking the members of all of our staffs, OHA, OHS, and CID, for all the work they put in to make today possible. There was a tremendous amount of work that went on in the background, and I am grateful to them. I think we all are grateful to them for what they've done to help us move forward on this very important topic. As Ted just mentioned, I'm really looking forward to hearing from today's panel. I think the first panel is going to be on the main drivers of healthcare costs in Connecticut and in the US. However, I will not be moderating that panel. What I will do is turn it over to my Assistant Deputy Commissioner for Life and Health, Paul Lombardo. Paul?
Thanks, Commissioner. Thanks, Ted, and thanks, Kim. Thank everybody for being here. As Commissioner Mays just identified, the first panel will be discussing the main drivers of healthcare costs in the US and in Connecticut. And our first presenter is Cynthia Cox, VP at Kaiser Family Foundation. Cynthia?
Hi, everybody. Are you able to hear me okay?
Yes, we are, Cynthia. Thank you.
Okay. It's great to be here. I have some slides to share, and I'm not sure if you were pulling them up on your screen or if you want me to share them on my screen.
I've given you permission to share.
Okay, great. So give me 1 second, sorry. All right, here we go. So I'm Cynthia Cox. I'm a vice president at KFF, and we're known as Kaiser Family Foundation, but I should let you all know that we're not affiliated with Kaiser Permanente. We're an independent research organization. And my job is to look at healthcare costs and affordability. I lead our program on the Affordable Care Act, and I also lead a project that's looking at healthcare costs at the system level for the US. So I'm going to talk about both how healthcare costs in Connecticut have changed over time and also how the US compares to other countries. I'm going to zoom in a little bit on healthcare prices in particular, and also how the pandemic has changed some longstanding trends in the healthcare system. And then I'm going to end by talking about what this all means for consumers or everyday people. So to start out, let's look at Connecticut and see how.
Cynthia,
Oh,
this
yeah.
is Commissioner Mays. If you could just pause for 1 minute, because
Sure.
we are having some audio difficulties here.
Okay.
And if you, we want to make sure that everybody can hear everything you say. So while they raise the volume, and if you will just tell me when it's time for us to restart. Apologies, Cynthia.
No worries.
Technical difficulties early in the morning. Cynthia, I think we're good to go now. Let's try and see how this works.
All right, can you hear me better now?
Superbly. Thank you.
Okay, great. So just to recap, I'm Cynthia Cox with KFF, which is Kaiser Family Foundation. We're not affiliated with Kaiser Permanente. We're an independent, nonpartisan research organization or think tank. And I'm here to talk about how Connecticut's healthcare costs have grown and how they compare to other states. I'm also going to be looking at the US more broadly and how it compares to similar countries. And I'll also talk about how prices for healthcare have grown and how the pandemic has kind of shifted some of the drivers in healthcare costs. And then I'll wrap up by talking about how consumers are affected. So let's start out by looking at Connecticut and how it compares to other states. So Connecticut has higher than average healthcare costs. In fact, it ranks number 9 of all 50 states plus DC when we look at per capita or per person healthcare spending. And so in 2020, Connecticut spent an average of $12,500 per person on healthcare. That includes spending that's by private insurers and out-of-pocket and public programs. Whereas in the US, the average was $10,000 or so. Going to the next slide. Connecticut's ACA marketplace premiums also reflect this higher spending. In Connecticut, the benchmark premium is ranked number 5 out of all 50 states plus DC at $627 per month compared to an average of about $460 per month in the US. And once again, when we look at another way of looking at healthcare costs, this is looking at employer premiums. Again, we see Connecticut's costs rise towards the top. Connecticut's ranked number 12 of 50 states plus DC with average employer premiums of $7,700 per year compared to the US's $7,400. So a little bit less of a gap there for the employer premiums. So now we can look over time. And here we're comparing per capita health spending growth in Connecticut, which is in yellow, to the United States, which is in orange. And you can see a few decades ago in the 90s, healthcare spending in Connecticut was a little bit more similar to spending in the rest of the United States, but healthcare costs in Connecticut have grown a bit faster than health spending in the rest of the US. Now this is, I just want to pause for a second and say this is per person health spending. This is not adjusted for age or health status. So some of the difference here could be in the underlying population of Connecticut compared to other states. Now, the 3 main areas that we spend, that most healthcare dollars go to in any state or any country really, are hospitals, physicians, and prescription drugs. And so here I've looked at how spending on each of those 3 areas has changed. I apologize because here the colors changed. So the US is now yellow and Connecticut is orange. So that you can see that for hospitals, physicians, and prescription drugs, Connecticut spends more on just about every type of healthcare service or good in this case. And it used to be more similar in the 90s, but there's been this kind of growing gap on each of these types of services. So now we'll take a step back and look at the US and see how the US compares to other countries' healthcare spending. And here for the next few slides, I'll be relying mostly on OECD data. OECD member nations report their health spending in a very comparable way to each other. And so we're able to look across countries. Here I've limited it to OECD nations that are above average in their GDP and above average GDP per person. So basically large and wealthy countries as a comparison, because healthcare costs are highly correlated with the wealth of a nation. So you can see that even just looking at similarly large and wealthy countries, the US spends about twice as much per person on healthcare as other countries do. And again, back in this case, back in the 70s, healthcare spending was more similar in the US relative to other countries, whereas other countries have seen a slower growth rate over time. In the US, healthcare spending has grown more rapidly, which is how we've gotten this kind of divergent path here. So there's a couple different ways that healthcare costs can grow. On one hand, maybe we are just using a lot of healthcare. Maybe people in the United States just value their health more, and we are using more healthcare than people in other countries. Or maybe we're paying higher prices for the healthcare that we are using. So here we can look at some measures of price and utilization to see, well, which one of those is the main driver of the difference here. So first, we're looking at the number of doctor's visits that people get per person. And here, it does not appear that the US is using more healthcare than other countries do. In fact, it looks like we're using a little bit less. We have fewer doctor's visits per person than most other comparably larger wealthy countries do. Here's another measure of utilization. Here, Japan is really driving up the average, but you can still see that in the US, we have shorter average hospital stays than most other comparably large and wealthy countries do. Now, a caveat here is that this is just looking at the length of stay. It's not looking at the intensity of the service that's being delivered. But again, we're not really seeing a lot of evidence that people in the US are getting more healthcare than people in other countries are. So now we can look at some prices. And here you can see that in the US, we spend more for an MRI. We have higher prices for MRIs. We have higher prices for certain prescription drugs. Although, again, a caveat here is that the prescription drug spending is not net of rebates. So it's a little bit more difficult to do a comparison there. And again, looking at surgeries or procedures, you can see for angioplasty or bypass surgery or cesarean sections, again, the US spends more than most of its peers, at least where we have data available. Again, as I mentioned before, this does not account for service intensity, which is a more difficult thing to measure, but we are seeing that when it comes to price and utilization, it becomes more clear that the difference in spending between the US and its peers is not so much driven by us just using a lot of healthcare, it's more driven by the prices that we're paying for the healthcare that we get. So this is, again, using OECD data where we can break out health spending by the type of service that people are getting, both in the US and in similarly large and wealthy countries. And as you can see here, we spend more on just about everything. So we spend more on inpatient and outpatient care, we spend more on prescription drugs, we spend more on the administration of healthcare, like insurance company overhead or running government programs. The one thing that we don't spend more on is long-term care. That's where other countries spend more money than we do, interestingly. But when it comes to administrative costs, which includes insurer overhead or profits or the cost of running government programs, we spend about 4 times more than these other countries. Some of these other countries are single payer, whereas others also are multi-payer systems. So that might be part of the explanation. Then also when we look at prescription drugs in the US, we spend about, at least in 2018, we spent about $1,400 per person on prescription drugs, whereas other countries spent about $800 per person. And where you see the big difference, though, is in that dark blue section, which is a combination of inpatient and outpatient care, so hospitals and physicians and clinics. We grouped them together here because there might be some differences in how other countries do inpatient versus outpatient procedures, so we kind of lumped it all together here. Now, in both the US and in other countries, inpatient and outpatient care is the bulk of healthcare spending, and it makes sense. That's where we're seeing the doctor, we're going to the hospital, that's how we're getting care. But at the same time, that's really driving most of the difference in the spending between the US and other countries. About 70% or more of the difference in what we're spending on healthcare boils down to what we're spending on inpatient and outpatient care. So I'll go to the next slide. So if we're spending so much money on healthcare, we would at least hope that we're getting better health outcomes. We would hope that we might be living longer lives or having better quality of life. That's unfortunately not the case. We're not seeing that this high healthcare spending is translating to better health outcomes. In fact, in the US, we live shorter lives on average than people in other countries do. There's one other complicating factor, though, which is social determinants of health. And this is kind of outside of the purview of the healthcare system in many ways. But when you look at the US in terms of income inequality or poverty rates, the US rises to the top of comparable countries. We don't, on average, drink alcohol or smoke cigarettes as much as other countries, if people in other countries do, but we do have a higher BMI, so more rates of obesity in the US compared to other countries. So maybe maybe part of the reason that we spend so much more on healthcare isn't all attributable to our healthcare system, but maybe part of it is the kind of underlying health or social circumstances in the US. And what's interesting is that although we spend much more on healthcare in the US than other countries do, we actually spend less on social services. But when you add the two together, we spend about the same. So just food for thought in terms of what other drivers of healthcare costs and outcomes there could be outside of the healthcare system. So now going back to healthcare costs in the US and how they've grown over time, I want to just show how this can vary by payer. So this is looking at per enrollee spending. And you can see that on a per person basis, spending through private insurance has grown faster than spending on Medicaid or Medicare. And here we're looking at prices or price growth. And you can see that on average over time, healthcare prices in the US have grown faster than the rest of our economy. When we break that down into types of payers, we see that prices paid by private insurers have grown much more rapidly than prices paid by Medicare or Medicaid. And on the next slide. So I do want to also acknowledge, though, that the pandemic has really changed a lot of the longstanding trends that we've seen in the healthcare system. So first of all, when the pandemic hit, as I'm sure many of you remember, we were all avoiding even leaving our houses. We weren't going to the movie theater or restaurants, and we also were avoiding the doctor's office and only going if we really had to. And so what we saw was that there was a very sharp drop in utilization of healthcare services. It started rebounding as people kind of started getting back to normal shortly thereafter, especially after vaccinations. But it's still hard to tell how that missed care is going to affect healthcare in the long run. A lot of the care that was missed was preventative or routine care, like cancer screenings. And so, as people come back and start using healthcare again, it's not clear how much of that care they're going to need to use still, or how much of that missed care might lead to worse health outcomes in the long run. There's also been a major shift towards telemedicine, and I think telemedicine is here to stay. Before the pandemic, it was virtually non-existent, but then after the pandemic, it became a major way that a lot of people are accessing care, in particular mental health care. And although the rates have been dropping off, I think it is it's going to be hard to get rid of telemedicine. I don't think that's what anyone's goal is. But I think what the question is going to be going forward is how much of this is actually going to lower costs versus how much of it might be duplicative of care that also happens in person. And as I think many of you have probably heard, in the healthcare system, as well as in the rest of the economy, there have been changes in employment rates and job openings and the rates of people quitting their jobs. In the healthcare sector, we are projecting basically based on pre-pandemic trends of growth of how many people would have been employed in the healthcare sector. And we're seeing that, at least as of this late summer, we were seeing that healthcare employment was still below what our expectations would have been based on pre-pandemic trends. And again, this is as of summer. The numbers have changed a little bit since then, but we also saw that there were high rates of people quitting their jobs and high rates of job openings in the healthcare system as well. Of course, inflation has been on everybody's mind. And one thing that's interesting here is that usually inflation in the healthcare sector is faster or higher than inflation in the rest of the economy. But we've seen that with prices growing so much in some other parts of the economy that healthcare price growth, while still high, is not as high as in the rest of the economy. And it's not clear whether or how soon some of that price growth or inflation in the rest of the economy might flow through into the healthcare sector too. So I want to wrap up by talking about what this means for people, for healthcare consumers. So first of all, out-of-pocket costs have grown over time. Even when you adjust for inflation, we're still spending more out of pocket than we did, a couple decades ago. A lot of that is being driven by in employer plans, people having higher and higher deductibles. Deductibles are becoming more and more common in employer plans. And especially for small employers, now the average deductible is $2,500, which has grown pretty significantly over time. So employers are looking for ways to limit their own healthcare costs. And part of that strategy is to raise deductibles or to increase premium contributions that employees make. And you can see that lower income employees are particularly hard hit by this. They are spending a much larger share of their income on premiums and out-of-pocket costs than their higher income peers are. And of course, many Americans struggle with healthcare costs. When we ask people to just list the things that they struggle affording, whether it's healthcare costs or anything else, healthcare is 5 of the top 10 things that people are having trouble paying for. So, beyond their rent or mortgage, what rises to the top is out-of-pocket costs that aren't covered by their insurance, dental care, and hearing and vision. And part of the reason for this also is that people are living paycheck to paycheck and just do not have enough liquid assets in their bank accounts or savings accounts to be able to pay for a large upfront cost, which is what a deductible or meeting their out-of-pocket maximum would mean. And so there are, a number of families that just don't have the money in their bank accounts that would allow them to afford a typical deductible or out-of-pocket maximum in employer plans. So again, this is just another way of looking at the assets, but at least half of ESI enrollees would not have the money in their accounts to be able to afford the maximum out-of-pocket amount that's typical in employer plans. So it's unsurprising then that there are so many people who are experiencing healthcare debt or medical debt. And we've done several surveys and research projects looking at medical debt and the impacts of that debt. One thing that's worth noting is that sometimes healthcare debt or medical debt doesn't really show up as such in a credit report. A lot of times people are paying for these bills on their credit cards and it's looking like credit card debt, or they're not paying their mortgage and they're getting foreclosed upon. So, healthcare debt can manifest in a lot of different ways and it can be masked by other forms of debt. And when we ask people who are experiencing this debt what they have done, 6 in 10 people have said that they were cutting back on basic spending like food or clothing or household items. About half of people said they used up most or all of their savings. And of course, there have been other sacrifices that people are making in order to afford their healthcare and to pay off the debt that they have. I do want to end on a somewhat positive note, though, which is that with implementation of the Affordable Care Act, although there are still many, many people, particularly sicker and lower income people who are struggling with healthcare costs, we do at least see that there's been some improvement in that over the years after the ACA was implemented. So just to kind of wrap up, in conclusion, we see that healthcare costs in Connecticut are higher than in most other states and rising more quickly than in other states. The US spends more on healthcare than any other country, even other large and wealthy countries. And prices seem to be driving most of that difference, more so than utilization of healthcare. And when we look at dollar for dollar, kind of where the big differences are, it's in everything that we spend money on in healthcare. You know, we're spending more on every type of service, but because inpatient and outpatient care is the bulk of spending, that's also kind of the bulk of the difference in where our costs are going. And prices in the healthcare system tend to rise faster than the rest of the economy, although now gas prices are giving healthcare prices a run for their money. And the pandemic has changed a lot of the long-term trends in healthcare, and it's really hard to predict how it's going to continue to unfold. I think there's been so many fundamental changes in the healthcare system that we're still kind of figuring out what the long-term impact of the pandemic will be. But finally, just to wrap up, these high healthcare costs mean that Americans are struggling with these costs, and it's flowing into other aspects of their lives too. You know, it means that they're not able to afford basic necessities or afford housing or you know, other kinds of needs that Americans have. And so it's just to drive this home, that high healthcare costs are a really important issue for people in the US. And that's my presentation. I'll pass it back to you.
Cynthia, thank you so much for that presentation. A great overview of not only Connecticut, but the US compared to other countries internationally. We're going to allow the industry perspectives for 10 minutes each, and then the moderators will have an opportunity to ask questions, and we'll allow the panelists to ask any questions as well. So the first industry perspective from the Pharmaceutical Care Management Association, or PCMA, is Sam Hollemeyer. Sam?
Thank you, Deputy Commissioner. Good morning. My name is Sam Hollemeyer with Pharmaceutical Care Management Association, otherwise known as PCMA. I'm Director of State Affairs, primarily working in the Northeast, including Connecticut. PCMA represents America's Pharmacy Benefit Managers, otherwise known as PBMs. I want to thank the CID, OHS, and OHA for participating in this joint session to discuss healthcare drivers in the state. And then next slide. I should have some slides. Sorry, I should have waited before I started. Yes, there we go. So next slide, please. Excellent. So who are the clients that PBMs work with? So PBMs work with plan sponsors and payers who are typically large employers, small employers, health insurers, labor unions, Medicare, Medicaid, and other government employee plans, such as the state employee plan here in Connecticut. PBMs work with these plan sponsors and listen to their wants and needs when building these benefits. PBMs are an instrumental tool in the healthcare space that promote both healthcare outcomes while also bringing down the overall cost by using of prescription drugs by using a full range of PBM tools. But ultimately, the PBM works for these plan sponsors. Next slide, please. So why do they hire PBMs? Well, PBMs exist for one reason and one reason only. They're the only entity in the drug supply chain with the sole purpose of putting downward pressure on the cost of prescription drugs. None of these plan sponsors that I mentioned in the previous slide even have to use a PBM. They choose to do so because these PBMs save on 40 to 50% on costs when compared to plan sponsors without a PBM. PBMs also improve healthcare quality and patient outcomes as well. They do this by reducing medication errors through utilization management, improve patient adherence, which is making sure that patients refill their prescription drugs and are taking them. But then also PBMs have various programs such as opioid programs, which are robust to address opioid issues and prohibit abuse. Next slide, please. So in the previous slide, I talked about what it would or how much PBMs save plan sponsors. This kind of captures what it looks like if a plan had a PBM or did not have a PBM. PBMs do not set or have any say in the price of a drug. Again, we exist to drive down the cost through PBM tools, which I'm going to go into a little bit here shortly, but this image captures what PBMs are able to do on the list price of drugs. Next slide, please. So I'm sure you all have seen an iteration of this slide before of the drug supply chain. It's pretty complicated. There's a lot of players involved and a lot of arrows here, but I'm going to focus on 3 relationships specifically. The first one I'm going to focus on is the PBM and patient payer, or the plan sponsor relationship. And then I'm going to go into the PBM and drug manufacturer relationship. And finally, the PBM and the pharmacy relationship. But I will share that each of these relationships, the role of the PBM again is to lower costs. And we do that by using PBM tools and competition. Next slide, please. So this first slide I'm going to talk about here is the PBM relationship between the patients and then the payers or plan sponsor. Next slide. So it's talking about competition. So PBMs compete for business amongst these plan sponsors. For example, the state employee plan here in Connecticut, they use a PBM. And that the state employee plan here in Connecticut has the option to shop for a new PBM if they choose to do so. Various PBMs will come in and compete on price and services that best fit the need of the state employee plan here in Connecticut, again, for example. To build these benefits, PBMs offer a variety of tools to control costs. Some of these tools include creating competition among the drug manufacturers as in the form of rebates, and then again, competition with pharmacies in the form of networks. But PBMs also offer mail order and have specialty pharmacy services to save on costs. This is where we probably get tagged as the middleman, as I'm sure you've heard, which I'm going to get to in a little bit, between the relationship between PBMs and pharmacies and drug manufacturers. Next slide, please. So these are the various tools that PBMs have to drive down costs. Our concern with any policy to limit or take away these tools, our viewpoint is that will raise costs in the state for patients and payers. And I'm going to use the insulin copay cap as an example. So Connecticut did pass a copay cap a couple years ago at $35 a month. And while yes, it will benefit the patient at the pharmacy counter and knowing what they're going to pay going in and when they do make that payment. And I acknowledge that is great for the patient. Having that said, it does shield the drug makers of those insulin products from raising their prices and scrutiny that may come with that. Again, although patients won't feel those increases at the pharmacy counter, they will feel those with raised premiums because the plan is paying more, but then obviously the plan will feel those raises on prices as they pay for those insulin medications. Next slide, please. This is just a quick capture of how the patients will pay in 2 ways. The first one is premiums. Those are usually through monthly payments. And then at the pharmacy counter through copays, deductibles, and out-of-pocket costs. Again, those are built and selected by the plan sponsors that the patient belongs to. Next slide, please. Next, I'm going to talk about the link between PBMs and drug manufacturers. Next slide. So again, drug manufacturers alone set the price of the drug. But PBMs have tools such as rebates to lower costs for plan sponsors and patients. Over time, PBMs will accrue those rebates through those claims and then pass those rebates back to the plan sponsor, but then it's up to the plan sponsor to decide what they will do with that money. PBMs will then use the patient population they have, as well as formulary placement, to negotiate these rebates I just mentioned. Drug manufacturers, again, compete, and again, compete is the main focus here. They'll compete to make the formulary by offering price concessions such as rebates. Next slide, please. So out of all the parts of the drug supply chain, here is a slide on the profit margins. And as you can see, PBMs make the least profit. The figures you see on this graph and then manufacturers are the ones that make the most profit here. And they're also the ones that set the price of the drug. Even pharmacies typically make more than PBMs. Next slide. Lastly, I want to talk about the link between PBMs and pharmacies. Next slide. PBMs negotiate with pharmacies to build robust networks. The pharmacies compete on offering lower cost prescriptions to be added to preferred networks. So I talked about it earlier, but PBMs also offer mail order on maintenance drugs at an even lower cost, and again with our specialty pharmacies to offer lower cost medications. So I've talked about the relationship between PBMs and drug manufacturers and pharmacies, and I'd said I'd bring up again the term middlemen, and it's something I actually like to own as a PBM. It's because we do stand in the middle between the drug manufacturers and the pharmacies. But while we stand there, we are the ones that are driving costs down between those two entities. And by driving costs down, we reduce profits for those pharmacies and drug manufacturers, which is why we've been coined the term middlemen, which again, I like to own. And then finally, next slide. Every link is essential that I mentioned on that busy, complicated slide with all those arrows. Every member of the supply chain does provide a product or service for patients. And then every link on that supply chain relies on the products or services of the other entities in that. But again, as you heard from a previous presenter, it's the high prices that we're finding is the problem in Connecticut. And again, PBMs are the only member of the drug supply chain putting downward pressure on these costs. And that's going to wrap it up for me today. And I'll be happy to answer any questions after the rest of the panelists.
Sam, thank you for your presentation. Next industry perspective will be from the Connecticut Hospital Association, Jim Acabellis and Paul Kidwell.
Good morning and thank you. I'm joined here, as you said, Paul, by my colleague and friend, Paul Kidwell. I'm Jim Acabellis, the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association. And we appreciate the invitation to be part of this conversation and are committed to this conversation. I want to start and pick up a thread that Cynthia mentioned. And she said, the pandemic has disrupted long-term trends in healthcare. Its effects continue to play out, and only time will tell what that impact will mean. Since 2020, Connecticut hospitals and health systems have been at the center of this global pandemic, acting as a critical partner to the state. We've stood up capacity, we've expanded critical care, we've stood up countless community COVID testing sites, and have been an essential part of the vaccine distribution plan. Through this all, hospitals and health systems continue to provide high quality care. But this pandemic has taken a significant toll on hospitals and health system and placed an enormous strain on our nation's healthcare workforce and in Connecticut. During this unprecedented public health crisis, hospitals and health systems have confronted many challenges, including historic volumes, revenue losses, as well as skyrocketing expenses. Hospitals and health systems have been nimble in responding to the surges throughout the pandemic. As I said, expanding treatment capacity, hiring staff, acquiring and maintaining adequate supplies and personal protective equipment to protect patients and staff, at the same time ensuring the programs continue. The credit here goes, and I need to say this really clearly and loudly, to our workforce. Throughout this pandemic, the response of Connecticut hospital workers has been inspiring. They have risked their lives and endured great personal sacrifices to attend to the care and well-being of patients, and in the process have saved thousands of lives. The pandemic has taken a heavy toll on our workforce, on our frontline workforce, who have suffered stress, trauma, and burnout. We owe them a lot. But as we speak, it's not over. Right now, as we are talking, our healthcare system continues to be significantly impacted by new challenges. Our two children's hospitals are caring for a significant number of pediatric patients with RSV. We're seeing increasing numbers of adults and children coming to the hospital with the flu, and we're likely to face an uptick in the COVID in the coming months. The New York Times is calling this in its headlines a triple-demic. That's where we are now. So as we look at these cost drivers, we must keep that into perspective. And I think Cynthia said it really, really clearly. We don't know. We know this pandemic has disrupted the healthcare system, but what does it mean going forward in terms of the cost and in terms of the structure? So again, we want to start and take a moment to thank all of the frontline workers that have done this. But let's sort of look now, and Paul and I are going to try to do this seamlessly and talk about different cost drivers in healthcare. And you will see each one of them has been impacted by the pandemic. Patients in hospitals are sicker today than they were pre-pandemic. You will hear that the acuity of the patients has gone up. And how do we measure that? We measure that in terms of length of stay, and we are seeing increased length of stay in Connecticut. So as hospitals treat patients for longer and that are sicker, that will have an impact on costs to the healthcare system. Medical supplies and personal protective equipment. Like all of us, in Prior to the pandemic, we used to go down to the store and buy paper towels right there and we didn't have to stockpile them, or we couldn't find them and stockpile them. That thread carries through into the medical supply and personal protective equipment. The United States, like most countries, relied on a global chain for goods and services. This is especially true for medical supplies used at hospitals and other healthcare settings. Everything from masks and gloves worn by staff used in patient care come from a large network of global suppliers. Prior to the pandemic, we had solid supply chains and vendors across the country and across the world that were providing, and we were buying, as we all were as consumers, supplies on demand. We're not doing that as much anymore. After the pandemic hit, many factories, distributors, and other vendors shut down their operation, leaving hospitals, which are on the front line, facing surging demand to go out and find supplies and personal protective equipment, often and at rates significantly higher than they were prior to the pandemic. The equipment, I should say the materials that create these supplies, resins, cottons, and most metals have surged 30%. They're all critical in medical supplies and devices used in hospitals. As COVID-19 cases surge, demands for hospital PPE, masks, gloves, eye protectors, and surgical gowns increased dramatically, causing hospitals to invest and acquire in maintaining reserves of these equipment. That has been a change that we have seen since the pandemic. If we look for an example, just at certain areas of departments of the hospital, medical supplies have increased in ICU upwards of 31% or 22%. These numbers, I think, help illustrate the magnitude of the impact that increases in supplies have led to hospital finances during the pandemic.
Thanks, Jim. I'll pick it up from there. Paul Kidwell again. Nice to be with you. And I want to talk a little bit about those expenses, those costs that exist in the system, certainly pre-pandemic, but have been certainly exacerbated by the pandemic. So first, starting with our workforce. So hospitals and health systems employ just over 100,000 individuals in the state and have a ripple effect of another 115,000 jobs in our state. Those expenses add up certainly well more than 50% of cost, but reach, approximately 60% in some instances. As Cynthia noted, we've had a tremendous amount of attrition in our workforce, and that has had us turning to staffing agencies to employ individuals, mainly nurses, to continue to provide that important care. Those costs are for a staffing agency are significantly higher than what we experienced prior. So that is certainly an enormous cost that we're managing through now. The other thing that we wanted to note is making sure patients are in the right site of care. So using behavioral health as an example, the legislature spent a significant, important amount of time last session on ensuring that there were resources available for child and adolescent patients, behavioral health patients, investing significant funds in the community. We continue to struggle, and we're very excited about those investments, but we continue to struggle to ensure that patients that no longer need an inpatient level of care can find the right level of care outside of the inpatient setting, either in the community, in a state-funded bed. And we know there are a number of reasons for that. Staffing remains a challenge, funding remains a challenge, but to the extent patients are in the hospital when they don't require that level of care any longer, that adds costs. To the extent a behavioral health patient is in our emergency department because they can't get an inpatient bed because we can't make those beds available, that adds costs to the system. They all aggregate. Some of the other work, we're doing with our friends in the insurance industry is what are the practices that we go through with each other to ensure that patients are again in the right side of care. So for example, there are a number of patients who need to come to the hospital and then return to a nursing home or a SNF for a period of time before returning home. There are processes that we work with the insurance industry to ensure that they can get there. Those processes at times, and certainly in the pandemic, can be burdensome, requiring clinical information, an available bed at a SNF, a staff bed at a SNF, someone to actually pick up the phone when the hospital calls to say, hey, we need to discharge this individual. We need those that all adds costs to the system. The other thing we want to mention certainly is most hospitals in Connecticut are not for profit. That does not mean that they do not pay taxes. I think most everyone here knows that.
Paul, I'm just going to ask you to wrap it up.
Oh, certainly. Sorry. I just making this point. Between 2012 and 2019, hospitals provided approximately $3 billion in revenue through our provider tax. Post the settlement that I think everyone is aware of, between 2020 and 2026, hospitals will provide $4 billion in revenue to the state in that time period. That's a cost that gets reflected in our payment structure. So you're going to hear a lot more around, I think, from Pat Charmel and Kurt Barwis later around payment and prices, et cetera. But these are some of the costs reflected in those payments.
So thank you, Paul, and I'll be real quick here. I just want to end with one last thought. We need to, as we look at solutions, and I'm glad you're talking about looking at solutions, we need to look at solutions that align some of our policy initiatives in Connecticut. I think if we can't be having conversations about increases in insurance premiums today, and then tomorrow adding new mandates to insurance coverage. We have to talk about what that means. We have to recognize what does the public want from hospitals? And do they want hospitals to provide every single service? How does that relate to the cost growth benchmark work that we're doing? Working hard with Kim and her team all the time on that. So these and the pandemic has changed the way patients and get their care. And how does that play into all this? We can't take the patient or the consumer out of this and look at what they are looking for, because that's going to impact the cost. So we have to have an honest conversation about that. And thank you.
Great. Thanks, Jim. Thanks, Paul. Our next industry perspective is from America's Health Insurance Plans. Miranda Motters, Senior Vice President. Miranda.
Good morning. Thank you for having me here today. I do have a set of slides, so I'm not sure if you'd like me to share them myself or share them there in the room.
I'm going to ask Alex to do that.
Wonderful. Thank you
Thanks.
so much. Thank you. So as Mr. Lombardo said, I am Miranda Motter. I am the Senior Vice President of State Affairs and Policy for AHIP. I am extremely grateful for the opportunity to be here today, and grateful to the Connecticut Insurance Department, the Office of the Healthcare Advocate, the Office of Health Strategy for hosting today's informational session and really bringing together a group of stakeholders and thought leaders to discuss the various cost drivers that are contributing to the rising cost of healthcare and health insurance premiums. America's Health Insurance Plans, or AHIP, is the national association whose members provide healthcare coverage and solutions to millions of Americans all across the country and a number of residents there in the state of Connecticut. Our members are national carriers, they're regional carriers, they're local plans, they're homegrown plans. They're also part of integrated health systems. They're providing healthcare coverage to individuals on the exchange through public programs like Medicare and Medicaid, and to employers in the fully insured market, and providing support and assistance to those employers who have decided to self-insure. Again, all over the country and in your state as well. We really believe that this diversity of membership is critically important because it really brings together the best thinking and thought leaders to drive innovations, to drive the solutions that we know are needed to ensure that we've got more equitable, affordable, sustainable healthcare systems that will allow all Americans to access the care that they need today. So with that, let me say, if you remember nothing else from my presentation this morning, I hope that you remember three things. First, that health insurance is critically important. If Americans across this country, it helps Americans across this country access healthcare. It helps them finance their future healthcare costs. And for so many Americans without health insurance, they would not be able to access the healthcare that they need. Second, healthcare is expensive. We've heard that already this morning, and healthcare prices continue to increase. I know that Cynthia spent some time on that already. And health insurance reflects the cost of what it costs to purchase healthcare. So if health care
Miranda,
are going up,
Miranda,
yes,
I'm going to interrupt you for 1 second.
Sure.
Do you want Alex to progress through the slides?
absolutely. And I will, again, that's perfect. I will ask him to move forward when I'm ready. So thank you.
Thank you.
Yep. So if health insurance costs go up, it's a reflection that the underlying healthcare costs are going up. And then lastly, again, as a takeaway, if you remember nothing else, we, I think, are all here today because we know that we must tackle that underlying cost of care. And so we stand ready to do that here with you today. So again, let's start looking at the healthcare dollar. We believe at AHIP and our member plans do that Americans deserve to know how their healthcare premium dollar is being used and how it is being spent. And so to provide this insight, we have put together this healthcare dollar. So it actually analyzes 3 years of data from 2018 to 2020, showing where your premium dollar is spent in the commercial market. So in the employer provided coverage and in the individual market. I think the costs here really underscore that we need solutions in major areas of healthcare spend. As you can see here, the analysis shows that prescription drugs account for 22.2% of spend. And then as you look at hospital costs, inpatient hospital costs, outpatient hospital costs, emergency room costs at 19 cents, 19.9 cents, and 3 cents really is the second major bucket, with doctor's office visits being at 11.8 cents on the dollar. So let's take a look at, again, sort of drilling down on these three major categories of spend. You can go to the next slide. As we think about prescription drugs, again, 22.2 cents of every premium dollar is spent on prescription drugs. Let me say at the outset that drug makers create life-sustaining treatments and breakthroughs, breakthrough cures. We have seen that through COVID, and we know that. But as you look at the spend, we also know that prices, whether it's launch prices or increases, are unsustainable. And if drugs are unaffordable, they are of use to no one, right? And so as you look at what some of the cost drivers are, why are drug prices so expensive? Why are they out of control? Really, the short answer is that the market is broken. And you can see here really three categories of that brokenness. First, as it relates to government granted monopolies, the market is dysfunctional. It doesn't function as it ought to. And then, third, there are limits that are placed on, whether it's at the state level or at the federal level, directly or indirectly, that limit purchasers. And when we're talking about purchasers, we're talking about employers' ability to demand value and drive down price. You'll see here on this teeter-totter, on the right-hand side, each one of these really can fall into one of those buckets, whether we're talking about coverage mandates, whether we're talking about pharmacy reimbursements, whether you're talking about copay caps. I know that Sam talked about those earlier. Well, each one of those may have a laudable sort of individual constituent patient value. When you look at all of these things together, it continues to create this dysfunctional market, which will really, at the end of the day, creates this unsustainable spend. We can go to the next slide. Recently, we have seen efforts to advance specific reforms in state capitals all across the country, which honestly act to further disguise and encourage, at the end of the day, higher launch prices and higher increases year over year. I will tell you that these efforts, sometimes you may hear them referred to as pharmacy counter reforms, and they are reforms, they're policy measures that are advanced in the name of providing relief to the patient at the pharmacy counter, those patients who are so desperate to afford those life-saving altering drugs. But what happens is that then will actually shift the drug spend to other healthcare consumers who are also struggling to afford healthcare. So let me walk through here a quick example, because I do think that it helps sort of visualize what is happening and honestly what we're seeing across the country in state capitals. So copay coupons. Many of you are probably fully aware that these are promotions that drug manufacturers provide to specific patients for a short period of time. These promotions are offered primarily on brand name drugs that face competition for more affordable generics. The promotions are used as an incentive for patients to use the brand name drugs instead of lots of times that less expensive generic drug. And once the patient hits their deductible, so once they've hit that out of pocket insurance costs, that promotion is pulled from that patient, and they no longer have the opportunity to utilize a coupon. And what it actually does is it encourages drug manufacturers to keep prices high, with patients, employers, employees ultimately paying the price. So here, these two slides, this slide, the fourth slide and the fifth slide illustrate this point. You can see with the patient sort of traveling along and the impact of what a tier 2 drug copay may be versus a tier 3 copay, and they can actually feel that financial pressure, right? At $25 for a copay or at $50 for a copay. If you'll go to the next slide, you can see what the impact of a coupon does. Here on the left side, there you can see that same patient as they're walking along. And if they're offered a coupon, why they may leapfrog over that less expensive tier 2 copay for a more expensive drug because they have that coupon at the pharmacy counter and they're actually able to feel significant relief, which we know that they need. But you can see here at the bottom of that line how that impacts the rest of the purchasers. So when I say purchasers, it's really about the employers who across the country and in your state who are really trying to continue to provide healthcare for the employees and their employees that so desperately need it. Next year, I will also sort of tell you that we are anticipating that these are the kinds of policy proposals that we will see across the country in about 24 different states. And so why I raise it here today is really to, again, bring awareness to make sure that as we are thinking about employers and the struggles that they are having to make sure that they can continue to provide healthcare, that they are really engaging in these conversations. We can go to the next slide, which here is the focus on hospital costs, again, which is the next sort of major bucket. Yes.
Miranda, I'm going to ask you to wrap it up, please. Yep. Thank you.
Absolutely. So hospital cost drivers, again, consolidation has a significant impact. The other thing we're seeing in the market is where physicians, hospitals are actually purchasing specialty drugs and marking those drugs up just because they're being purchased by a hospital or sitting on a hospital shelf for, again, the patient and the employer. Site neutral policies. And these are really instances where off hospital site campus or a provider site, a doctor's office has been purchased by a hospital, and the consumer, the patient, may be charged more, whether it's a facility fee or other kinds of fees, because it is now associated with that hospital. We can go to the next slide, which here is really talking about provider costs and really what we're seeing in the market in terms of private equity and how that is impacting cost drivers. Telehealth, we've already spent a lot of time talking about how incredibly important telehealth has been, but there is, I think, some cautions in terms of how to make sure that telehealth isn't causing cost to increase, but actually causing value and cost to go down in that space. And then certainly we are seeing some things nationally and across the country in terms of dialysis spend. So I wanted to note that as well. We can go to the next slide. Again, here I raised some of these issues in terms of what has happened there on the ground, not to really opine one way or the other, but as policymakers and as you all there are thinking about improvements to the system, really asking, are these measures improving affordability or are they challenging affordability? We can go to the next slide. I did want to mention some of the issues that we are paying very close attention to that are on the horizon with Medicaid redeterminations. This is an area that, although it is specific to Medicaid, could have significant impacts across markets. And so just want to make sure that I raise this as an issue for attentiveness for individuals that may lose their healthcare coverage, becoming now uninsured. That could also cause cost impacts and cost shifting that will occur in other places. We can go to the next slide just to leave you here again with some solutions that I know that will be talked about in the future. We can go to the last slide here at 11. Again, providing some 10 different areas that we really believe will bring further competition and restore competition to the market that will help drive down costs and improve access and affordability. And with that, I again thank you for the opportunity to spend some time with you today.
Thank you, Miranda. I want to make sure, and this is a question for Jim Carson, our communications person, and maybe Ted. These slide decks are going to be available for people.
So they're going to be up on the insurance committee's website, hopefully tomorrow.
Great. Thank you very much, Jim and Alex. And Miranda, thank you for your presentation. Next, we have Kelly Ryan, Vice President, State Policy, representing Pharma. Kelly?
Thank you so much. And I think I have some slides. My name is Kelly Ryan. I'm Deputy Vice President for State Policy, based just over the border in Albany, New York, but I've been covering Connecticut for a number of years and really happy to be back to have this very important conversation with you all. Just give it a second for slides to pop up. So we can go right to the next one. This is just a very quick level set slide. Exactly the issues we've been talking about all day, right? We know that there's a problem. We know that we need to work together and have a conversation about how to solve the problem. If we flip to the next slide, Pharma recently conducted what we call a patient experience survey, and I'm happy to provide that document to be included in the materials to go on the website. And we know that more than a third of insured Americans are facing at least one serious financial barrier to care, but that third isn't across the board, right? These financial barriers and these challenges impact different communities very differently, right? Women are harder hit, communities of color are harder hit, and specifically those in poor health are really hard hit. So just a quick touch point to keep in mind is we have fact-finding conversation today. At a future date, start to dig into solutions. Let's not lose track of the fact that we need to watch out for these disparities and this disproportionate impact. We can flip to the next slide. Just to dig in a little bit on something Cynthia teed up earlier. And this is specific in the prescription drug space, right? We've seen a very significant change in plan design in general. Part of that's driven by ACA rules, part of that's just driven by costs in the market. But in the drug space, we've seen a very large uptick in the number of plans that have a deductible on prescription drugs in the last 10 years or so, and a really large uptick in the number of plans that have 4 or more cost sharing tiers. And very often on those higher cost sharing tiers, there's coinsurance, which is based on a percentage of the list price. And this is important because we just issued research in the last week or so that shows patients pay 6 times more out of pocket for medicines when they have deductibles or coinsurance as compared to flat co-payments. If you're just looking at brand drugs, it's 8 times more. And this matters because patients are 4 times more likely to abandon their medicines if they have a deductible as opposed to a flat co-payment. And while we may talk about squeezing a balloon, right? It's either premiums and employer costs or it's out-of-patient costs and there's nowhere to wiggle. This is kind of the opposite of how insurance is supposed to work. The burden is placed on the sickest patients, those with chronic diseases that need to pick up their medication, and frankly, the poorest patients, right? Cynthia teed this up earlier. We know that bronze plans have really high deductibles. This is a problem. So we can't just sweep the challenge of out-of-pocket costs under the rug in the name of premiums. And it's also short-sighted from an overall cost perspective, which is what we're here to talk about today. Because as I'll dig into a little bit more later, managing disease states with proper adherence saves overall costs, right? So we want to be careful that we're not impeding patients' ability to access their medicines and then keep them out of the hospital where we know that there are more. So flipping to the next slide, the burden of out-of-pocket costs is particularly an issue in the pharmacy space. On the left, you see total US spending on hospitals as compared to total US spending on retail prescription drugs. These are from a 2021 analysis. But on the right, you see total out-of-patient pocket costs for those 2 categories. Now, by no means am I saying should we jack up out-of-pocket costs for hospitals, to match the proportion, but patients are definitely paying a disproportionate share out of pocket when it comes to their prescription drugs, as opposed to other services. And we flip ahead. At the same time, net prices for brand medicines have stayed fairly stable. They've been at or below the rate of inflation for a number of years. And it's been alluded to a couple of times today, but there is a significant gap between the list price and the net price of the drug. And on average, that's 49% different. And that continues to grow. And we'll dig into that a little bit more in a moment. And we can go to the next slide. Switching from prices to spending overall, spending on medicines has been a small and stable share of healthcare spending for a number of years. It represents about 14% of overall healthcare spending. And the little asterisk there, backing out COVID vaccines and treatments to points that were made earlier, that's been really disruptive in the last year or so. Per capita spending on medicines declined in 2021 by 1%. In fact, medicine spending per capita has increased just $204 since 2011, which is a 1.8% compound growth rate. And if we flip to the next slide, looking forward into some of the incredible therapies that are just coming onto market or on the horizon, these really transformative cell and gene therapies that are frankly expensive. The analysis shows that still the percentage of prescription drug spending, including the cell and gene therapies, which are like the tiny little red dots that if you need readers, you probably can't see there, right? It's not going to significantly disrupt the balance. Yet still we need to adjust, we need to bend the curve, right? A stable percentage of an increasing number is still a problem. But there's not anticipated to be a huge spike. As we start to talk about solutions going forward, I do think we need to rethink payment models, especially for these transformative therapies, right? The idea of a very large upfront payment as opposed to years and years and years of costs that add up to much more. It's just different from how the insurance system has handled costs like this in the past. And certainly need to have an open and frank conversation about encouraging those kind of innovative payment models. We flip to the next slide. The prescription drug space is the only piece of the healthcare pie where prices go down. Generic and biosimilar substitution drives significant savings. We're looking forward to seeing even better uptake of biosimilars in the next number of years to drive hundreds of billions of dollars of savings overall. In fact, savings from loss of exclusivity, so losing exclusive rights, a total of $93 billion between 2016 and 2021, more than offsetting the $87 billion spent on newly launched medicines over this period. We think that's a good thing, right? That this system is designed to build savings. We have a very high generic substitution rate here in the United States, higher than most other countries. That's a positive thing, and we hope to see biosimilars catch up to that as well. So if we go to the next slide, sort of circling back to dig in a little bit on a point I made earlier, the volume of discounts provided by brand manufacturers to PBMs, payers, other players in the system has tripled in the last 10 years. It is currently, the 2021 number is $236 billion. I certainly expect to see that number higher when we get numbers for 2022 and early next year. And on average, a medicine's net price is 49% lower than the list price. But as prices remain stable and this huge gap in list and net keeps growing, where is that money going? We know that patients are not really reaping the benefit of these discounts, right? If they're in the deductible, they're very often paying the full list price as opposed to the negotiated net price. Same thing during a coinsurance phase, they're paying the percentage of that list price as opposed to the often considerably lower net price. Now in Connecticut, the insurance department issues, the first one was in March of this year, an annual report that shows how carriers use rebates. That report came out of a 2018 law that included sort of, beginnings of system-wide transparency in the pharmaceutical space. There's some reporting for manufacturers, there's reporting for plans and PBMs. And what that report shows is some carriers are in fact factoring in rebates at the point of sale, but there's not a ton of detail. It is certainly not all carriers, and it is unclear whether it's, even the carriers that are doing it, is it all drug classes? Is there only certain drug classes? Like what's happening in that space? So we would love to see that report. It was just the first year. As that becomes a more mature report, really start to dig into that and understand how patients are benefiting from the significant discounts that are being provided. We can go to the next slide. Just another version of the supply chain that we've seen already today and many, many times every time we talk about this issue, that there are a number of players that all impact costs. And importantly, we can switch to the next slide. The impact of consolidation has been a topic in Connecticut for a long time, whether it's in the supply chain, whether it's in the hospital or provider space. I know there have been previous forums on that, but this is just a snapshot of the relationships that are involved in the pharmaceutical supply chain, right? Insurers and PBMs all either own or own each other. They all have specialty pharmacies. Many of them have specialty provider networks, right? So there is considerable vertical integration in market participants, and there's also, not on this slide, considerable horizontal consolidation. The top 3 PBMs represent 80% of the market. So as we talk about competition, that's an important number to keep in mind. And then also those large PBMs have a tendency to provide services for other smaller PBMs. So there's a lot of kind of like up, down, sideways connection in this market. So why does that matter? Go to the next slide. It matters because more than half of spending on brand drugs goes to players in the system other than the manufacturers that research and develop the medicines. Let me just say that again. More than half of spending in the brand drug space goes to players in the supply chain other than the manufacturers that take on the risk and develop the medicines. And that number has gone up over the last number of years, and I expect to see that going up. So we can't really have a serious conversation about managing costs, sort of trying to come up with meaningful solutions if we don't acknowledge that this is an incredibly vertically and horizontally integrated supply chain. And there's a frankly shocking amount of money that's getting lost throughout the system, and patients are not benefiting from it. And I know I'm probably getting close to time, so I'll wrap up quickly, but I just wanted to include, we can go to the next slide, a couple slides, circle back to a point that Cynthia started with, right? So I wrote down 70% of the difference between the US and other countries spending is in inpatient, outpatient. We shouldn't, as we start to have this conversation about bending the curve and really coming up with meaningful solutions, lose sight of the fact that prescription medicines are often the most cost-effective means of preventing and treating disease. Right. So if we look at costs in these buckets and we all point fingers at each other and we all sort of put our blinders on, we're not going to solve the problem. Accessing medicines keeps people out of the hospital, which saves system-wide costs. Innovative medicines, figures from the Alzheimer's Association, right? We're able to delay the onset of Alzheimer's disease by just 5 years. It'll save the system $367 billion with a B dollars. If we flip to the next slide, the cost of treating medicines to treat cardiovascular disease has come down significantly, while the cost for the surgical procedure to treat it has gone up. I think we would all say we would much rather be able to take a medicine and stay healthy and not end up in the hospital with surgery. And adherence on the next slide is really important. A small increase in spending on prescription drugs drives huge savings across the system. So the idea that spending on drugs, is de facto a bad thing, I think is a false narrative. And I'm happy to take questions when we have that conversation later. Thank you.
Kelly, thank you so much for your presentation. Our final industry perspective is from Lou Gianquinto, the president of Anthem Blue Cross and Blue Shield of Connecticut. Lou?
Thank you, Paul, and thank you to the host agencies for having us here today. This is an incredibly important topic, one that we work on a daily basis at Anthem Blue Cross Blue Shield. I'm Lou Gianquinto, president and general manager of Anthem Blue Cross and Blue Shield here in Connecticut. We serve about 1.2 million members across the state of Connecticut in really all segments, and in the individual exchange, in the small group marketplace, in the large group employer marketplace, and in Medicare. There was a lot of good points made today, and there's a few that I'd like to hit on. One particularly on the impact of the pandemic and the economic environment. Cynthia hit on that. Paul and Jim hit on that. That is a real issue that we see on a regular basis, and it is shifting the dynamic when it comes to cost trends. There was discussion before from Cynthia on the suppression of services in 2020. There was followed with significant spikes in COVID-related costs, behavioral health, and an influx in ICU days. And now in late 21 going into 2022, we have seen what is a spike in high dollar acute cases. And we do think that has a lot to do with the suppression of services for potentially 18 to 24 months. And these things are still transpiring and unfolding as we evaluate the data closing in on 2023 here. And then there's a new, and this was mentioned before in one of the presentations, there's something else that we are starting to see around respiratory issues, particularly with pediatric patients. And I do think that we will continue to see things unfold and trends unfold from the pandemic for really years to come. And it's something that if we're going to talk about affordability in the present tense, we have to acknowledge some of the impacts of the pandemic and how that's changing the landscape and could change it for the long term. Economic pressures were mentioned before, and that is real. Inflationary costs, labor shortages at hospital systems, supply chain issues for hospital systems. These are discussions that do come up between our provider partners and in our discussions, and it's something that we need to deal with in Connecticut. And all these factors, from the pandemic to the economic environment, will continue to play a role in the short and long term. And it's something we have to acknowledge as a panel that has to be part of the discussion as we continue. There is something else I wanted to mention, and it was brought up in one of the presentations. Is there's a critical event happening in 2023. As you know, the public health emergency was extended to January of 2023 at this point, and all likelihood, the public health emergency will end sometime probably early in 2023, and that will then trigger redetermination and recertifications of Medicaid membership over the next year. That is critical, and this is one of those areas of caution where we don't want to make the problem worse, and if we don't do things right here, this could end up causing a lot of members to become uninsured. So I know that some of the stats I've seen are 390,000 members were added to Medicaid during the pandemic. That is a critical number because that could be an indication of what we're looking at and risk to fall out of Medicaid. So this is vitally important. There are plans on the exchange. We are one of the participants in the exchange. There are plans on the exchange that have zero cost or very minimal cost. It is vitally important we get that message out to folks that could be recertified. It is also vitally important that we do everything we can do to reach these patients and members. This is something we will continue to work on with Department of Social Services, the communities we're in, as well as the providers and the hospital systems we work with. This is something that, if we do not do this correctly, could have a massive impact on an already inflated healthcare cost system here in Connecticut. Lastly, I want to talk a little bit about really kind of a theme that we need to think about as we talk about solutions to this problem. And really it really comes down to me to collaboration and partnerships and moving to value and within value, moving to risk together between providers and payers. We need to move away from fee for service. That is something that I've made a priority since coming to this role in December of 2020, is that we need to continue to move the maturity of our value-based programs to downside risk. That will inherently do several things. Number one, it will incent and drive member engagement with primary care and increase the emphasis on prevention. It will also support our providers with care coordination dollars so they can build administrative processes to coordinate and with their patients and ensure that they're accessing the healthcare system in the most effective way. Place specific programs around high cost cases, things like bundling, things like medical homes, and certain disease states will be inherent in some of these models. Ultimately align the goals and harness the strengths of payers with providers together in the effort to improve outcomes. And ultimately the improvement of outcomes will start driving costs and bending the trend. Those are things that we need to all think about when we talk about solutions at Anthem. This has been a cornerstone of our strategy with our partners in the provider network. On the Medicare side, we have about 74% of our total dollars that are spent in value deals. 42% of those deals are in downside risk in Medicare. On commercial, we have about 72% of our spend in value deals, and about 20% of that is in downside risk. And what we need to do is continue to grow both numbers. We need to grow the number of value deals, and we need to mature those value deals and increase the number of downside risk dollars that we have out there. And again, this is critical. And I've seen, worked in this industry a long time, and I've worked in several states. And when there is a shared and aligned risk and incentive between payers and providers, the partnership changes from one of volume and unit costs to one of how do we improve outcomes together, and how do we take the best of the payer and the best of the provider with that patient right there at the point of service, and ensure that we get the patient to access the medical system the right way and in the most efficient way with the highest quality. So I'll close there. I am a firm believer that there is a lot to talk about. There is no silver bullet here. We have to first off identify all the levers and then begin to push and pull on those levers to ensure we get the right mix. But at the end of the day, it's going to be solved through collaboration and partnership versus blame. So I'll end there. Thank you.
Lou, thanks very much for that. And I'd like to take the opportunity now to thank all of our panelists for very insightful presentations, information. Given the fact that the commissioner's given me the ability to be the moderator for the first panel, that means that I get to ask a question before I turn it over to you, the panelists, and the other moderators. I'm going to ask you very succinctly in one sentence, each of you to identify what you perceive from your perspective to be the largest pain point that you have as a stakeholder in this healthcare delivery system. And Sam, since you were the first presenter, I'm going to ask you from the PCMA perspective and PBM perspective, what that most significant pain point today is.
Sure, happy to do so. Just to clarify the question, it's the pain point that we face in the state of Connecticut, where just overall.
Yeah, specifically in the state of Connecticut.
Got it. Okay.
Thank you.
That's a good question and put me on the spot. I would just say that, just our ability to not use the PBM tools that we have currently, or limiting those tools to create competition, to lower drug prices, I would say is our biggest barrier at the moment, off the top of my head.
Great. Thank you, Sam. Now the other panelists have an opportunity to gather their thoughts, and I apologize, Sam, you were the first up. Jim and Paul, please.
Our two biggest challenges, one is related to our workforce. We need the workforce to be able to care for the patients. We're in a significant workforce shortage, and the cost of finding nurses, especially, and physicians is staggering now. And the second, I think we need to focus in on what are some of the structural issues related to underfunding in the Medicare program, significant issues in the Medicaid program. So those, I think, would be two that are important. But the Medicaid program ties into what Lou said about we have an issue coming up with redeterminations that we have to get right, and it's on top of what is already challenges that we have, and in conversations with the commissioner of the Department of Social Services related to the time to get people enrolled in Medicaid. So the precursor to the eligibility problems is making us very nervous, on top of what Lou said, coming up with about 400,000 redeterminations.
Thanks, Jim and Paul. Miranda?
I think the single biggest thing is competition, whether you're looking at medical services or pharmacy services. And honestly, lots of times it's about, policy measures, right? Looking at this from a sort of a public policy perspective all across the country and there in the state. Sometimes it's about policy reforms that are done in the name of the reform that create continued dysfunction and don't restore competition. The other thing I would note again is Medicaid redeterminations and the impact that that is going to have across markets looking forward.
Thanks, Miranda. Kelly?
I'd say, the ability of patients to access their medicines at the pharmacy counter and, reap the benefits of flat net price growth when they're having a higher out of pocket. And I will flag, Connecticut has had standardized plans on the exchange for a long time. Just this year, so going into the 2023 plan year, like all of the plans on the federally facilitated exchange will now have standardized plans. And that plan design is really exciting in that it is largely co-payment only. Right, my watch is, there are deductibles, but there is no co-insurance in that plan design. So we think that's a really important step in the right direction. And a lot of sort of chronic medicines are provided pre-deductible. And we would encourage, Connecticut's been a leader in that. And let's make sure Connecticut's not falling behind the rest of the country when we look at standardized plan design and access at the counter.
Thanks, Kelly. And Lou?
Yeah, I'll make it relative to the top of affordability. It's member engagement for us. Engagement with their primary care physician, and engagement in preventive care, engagement in case management when they do have chronic issues, and really engagement when we talk about Medicaid redeterminations. It really is going to come down to engagement of the member and acknowledging when they may have an event that disenrolls them from Medicaid and how they get to another another plan.
Great, thanks, everybody. This next part will be an opportunity for each of the panelists, including Miranda and Cynthia, to ask each other any questions that they may have of the other panelists as part of a collaborative discussion. So I'll open it up. Again, this is supposed to be an open forum. Any question in a respectful manner is appreciated by the moderators. And anybody can step in and chime in when they want.
I guess I'll start, Paul. For Paul and Jim, when we talk about value-based programs and risk, and from your perspective, how are you guys feeling about that as a strategy going forward as part of the solution?
Thanks, Lou, for the question. So, I mean, as your statistics show, right? So in your commercial market, you got 72% in some sort of risk-based payment. So I think much of this is in the details of the negotiation around who are the patients? Is it disease specific? Is it total population health specific? What are the parameters of the risk? I would just note that we're cautious around downside risk, and given what the elements of the care look like. So how much of the care does the hospital or health system, how much of that care can we actually affect? And who are our partners in that, and are there willing partners in that? So I think we're open to the discussion. As you know, statistically, you're having those conversations with the hospitals and health systems. I think much of this is going to be in the detail, who the populations are, who the partners are, what the elements of the risk look like.
Totally agree. Yeah, I mean, that's the devil's in the details, and and it's important to understand in those conversations. I think what's vital is that there's a clear understanding of the needs, priorities, and challenges that each side faces before you even enter into a discussion.
Yeah, and maybe we could sort of, Cynthia, I think it harkened me back to Cynthia's related to social spending and investments in the community. Certainly something we're thinking about how can investments in the community and non-healthcare spending affect what happens in healthcare. So, we're thinking about those economic drivers. So for example, I mean, one basic example, we know that part of being able for individuals who have small children, part of being able to make sure you can go to work, you can go to daycare, is having an available source of diapers. So we are engaging with our community partners, with hospitals, to screen individuals for diaper needs, so that we know that they're, individuals are in the hospital, we have access to them. Do they need diapers? We could connect you with someone to keep you, your employment stable, your ability to access childcare stable. So those are the types of things that we're thinking about, because we know that it's not just healthcare. There's a lot of other things, as we know, driving that use.
Sam?
Can I ask you, because you brought up the issue of redetermination, because we're thinking about it a lot.
Correct.
How are you thinking through it, or ways in which we can really crack what is going to be an important issue? So because I think we all need to work on it together, but I'd be interested in sort of what your thoughts are.
We really need to, and Anthem, if you look at Elevance Health and our footprint across the states, and Medicaid, it's quite deep. And in some of our commercial states, they have what we call a sister Medicaid plan, where it becomes very easy for them to work together. They have community reps. They go out into the communities, and there's a smoother transition. In Connecticut, it's a state-run Medicaid, and so a few of the things that we need to work on is just building a strong partnership with Department of Social Services, and that is happening. There's a great discussion going on right now between the two plans, Connecticut and Anthem, as well as Department of Social Services, on how we work together, and along with the exchange, on how we work together to make the transition as smooth as possible and educate as much as possible some of the members that are at risk of losing coverage. Second, how do we get into the community where we're going to find and be able to educate some members? Entities like FQHCs will become critical sources for us. Food shelters, barbershops, churches. We need to get staff and events going in those particular entities, and really, it's a grounds up education and assistance program, and partner with providers. There, in particularly in hospital systems, there is a clear understanding of which patients may be losing their coverage when there is access of services going on. And so how do we partner with hospital systems in getting co-events going within systems and putting staff there directly into the system to help in the transition as these things are happening. So it's really an effort of collaboration across the spectrum.
Sam, go ahead.
Thank you. I have a question for probably Jim and Paul and then Cynthia and Lou. So for those outpatient services where where doctors prescribe patients medications, do you see real-time benefit tools and e-prior authorization being helpful for your providers? Because what we're hearing is physicians are struggling with dealing with denials and prior authorizations and step therapies and such like, and things like that. And I've heard responses such as provider burnout and doctor burnout. Is real-time benefit tools helpful? And what can we do to keep that going and build upon that?
And I'll go first. And I know that we have sort of expert testimony on the next panel from the Medical Society, who probably can speak directly to the use of the EMR and those types of tools. I will say generally, we as hospitals and health systems spend administrative dollars, a significant administrative dollars, to comply with commercial and public insurance requirements, and that takes staff energy, that takes clinical energy. I think anything we can do to lessen the burden there on clinicians, especially, it would be largely welcome.
Thanks for that. I'm going to now turn it over to Ted, Kim, and Commissioner Mays to ask any of our panelists questions. Go ahead.
Great. Thanks so much, Paul. This is Ted Doolittle with the Office of the Healthcare Advocate. So my question is for Jim and Paul, who are representing the Connecticut Hospital Association. It's just a simple question that consumers have, even folks who are in network. Why are prices different at hospitals that are sometimes very close to each other for the same procedure?
So I think part of that, and thanks for the question. So part of this is what, Lou discussed. There's negotiations in the commercial space going on between hospitals and systems. And part of that negotiation may be some sort of value arrangement, different contractual reasons for that. If you look at, say, Medicare, certain input costs are associated with certain hospitals, and those prices are set by the federal government that way. But I think your fundamental point is it can be confusing to a consumer related to why that is. And I think I can't recall who noted it earlier, but there are now certainly if you are a consumer or a patient in Connecticut, all of our hospitals have tools on their websites where you can go in, look at the cost of a service and compare across hospitals and systems for those services. And certainly that's one element that may go into a decision about whether to get that service. But those are tools that are available today that certainly weren't available some time ago. And there's a lot more information available today than there were before. And so I think we're moving in a direction where there's some transparency and individuals can make some decisions that maybe they weren't able to make prior.
Thanks, Ted. I was listening to Miranda's response to Paula's question, and she mentioned competition. So I'm going to direct my question to Jim and Paul on the one hand and Lou on the other, as the representatives of us as consumers. If we look at the hospital situation in Connecticut, maybe 20 years ago, we had 30-something independent hospitals. We are down now to 4. We've got 3 big chains, 1 smaller chain. So Lou, on the side of the people who are supposed to be negotiating for us, certainly I'm on the state health plan, which you manage, and we expect you to come up with the lowest possible cost for good coverage. How does this affect what you do? And how best can we, certainly sitting on this side of the table, help to lower costs when you're faced with a situation where there is increasing both horizontal hospitals buying hospitals and vertical concentration with hospitals buying various provider networks? And I'm just going to give the same question to Jim and Paul. I know from your side, you say that this should help increase efficiencies, reduce the back office costs and all. How's that worked out? And what do you see yourself doing in order to lower costs for the people of Connecticut?
Thank you, Commissioner. Yeah. Look, there's it's pretty clear there is significant consolidation of the network here in Connecticut, and that does play a role in negotiations and the ability for us when we talk about things like unit cost in a fee-for-service model. Quite frankly, that will not end well for the insurance companies. This is why we have such a prioritization and shared strategy to go and move to value and outcomes as the driver and align incentives around those things versus a fee-for-service, essentially volume-based approach, where unit cost and volume are the drivers of cost versus outcomes and prevention and sharing in the total cost of care savings becomes more of those arrangements, shared downside risk, and those types of things will change the dynamic with in a consolidated network like this.
I think when we talk about consolidations and mergers, we can't talk about them as that they're all the same, because they're all different. And it's first important to say that every single one of the mergers and acquisitions that have happened in Connecticut have gone through approval through what was OCA, now the Office of Health Strategy, through a lengthy certificate of need process, and most times involves approval from the FTC. That looks at the FTC will look at the market and the market consolidation. So that's one step. And as I said, each one of them is different. We have seen acquisitions of hospitals who are struggling, and without working with a larger system, they would probably not be here today. And as we have seen in Connecticut, that hospitals are extraordinarily important to the communities in which they serve. And the community will support a variety of different structures, if you will, whether it's an independent hospital or a system, to make sure that their hospital is there today. We continue to see that. Is it a fair question? And the questions that we go through from the Office of Health Strategy on what do you think the outcomes will be? How will it impact prices? How will it impact quality? Absolutely fair conversation to have. OHS has them all the time. But we welcome the conversation because we saw the importance in Connecticut of all hospitals during that systems, hospitals will be able to work together to manage patients' flow during the pandemic, and community hospitals, smaller community hospitals, were integral parts of the COVID response. So I think they all play a different role, but I don't want to leave with the thought that hospitals simply have the ability to go out and acquire whoever they want without state regulation and state approval, because Connecticut has, and we've gone through 2 or 3 presentations, one in front of the healthcare cabinet, one in front of the insurance committee, where there has been a conversation about Connecticut's regulatory oversight of mergers and acquisition of physician practices. And we have the most comprehensive and complete laws almost in the country. There are very few states that have a certificate of need approval for acquisition of physician practices. We are one of them. So there is a regulatory process, and we support that regulatory process. But we support the questions that are part of that, because I think they're important. Is quality being, how does it impact quality? How does it impact cost? How does it impact consumers? And those are important questions that should be part of it. Would we also argue, and we've had conversations with Executive Director Kim Martone for years about, is the process as smooth and as it can be? No, we think there can be improvements, but the process in Connecticut is one of the strictest that looks at all of those issues. So I think that's important.
I have a few questions, but due to the timing, I'm just going to ask just one. I'm sorry, I'm asking Jim and Paul another question. I'm so sorry you're on the hot seat. I don't mean to do that. But just related to the presentation you gave, focusing on the paradigm shift due to COVID, which we all realize and understand. However, what about prior to COVID? So, we saw presentations this morning about the rising healthcare costs prior to COVID. So could you just respond to that question in terms of what your opinion is and your thoughts and your expertise on why those were rising healthcare costs prior to COVID?
So I think we tried to touch on some of these that were exacerbated. So workforce has always been an issue. It's 50 to 60% of total cost. I noted that there's a significant provider tax in the state of Connecticut that hospitals and health systems have been paying for some time. Acquisition costs of pharmaceuticals have certainly been pre-pandemic and post, working with commercial carriers related to different administrative needs. I think the next panel will talk a little bit about this as well. But if you think, we focus quite a bit on commercial spending and costs, but that's only one slice of the total picture. We have to spend some time thinking about government payers, specifically Medicare and Medicaid, and they're part of this. And if you look at our costs related to what we get reimbursed, Medicaid is about 68 cents and Medicare is about 88 cents. And on Medicare, even the most efficient hospitals in the country have a negative Medicare margin. That puts enormous pressure on the commercial space when your aggregated operating costs are expanding. Your government payers payment rates are pretty much set and rising, in some instances not rising at all and or below inflation. That puts enormous pressure on that commercial conversation. And so I think the next panel is going to talk a lot about that, but I think we've certainly a important focus on commercial market. We have to also have I think equal focus on the government side as well.
Thank you.
Yeah, I mean, and I think the next panel will get into what is, how do you look at commercial? How do you look at Medicare? How do you look at Medicare Advantage? How do you look at Medicaid? And whether you think there is a cost shift or not. When you talk about Medicare being at 88%, Medicaid at 68%, we can call it whatever we want. That's something that is important for us to consider.
Again, I'd like to thank all of the participants in panel one for their frank conversation, their presentations, and their willingness to be here and their willingness to respond to questions. At this point, we are right on time. We are going to take a 2-minute break, and then we will begin panel two. Thank you.
Okay, everybody. My name again is Ted Doolittle, Director of the Office of the Healthcare Advocate, and welcome to the panel 2 portion of the Healthcare Cost Drivers Forum hosted by my office, the Connecticut Insurance Department, and the Office of Health Strategy. So panel 2 is here, and I welcome them. Just real quickly to go through, I believe that on the phone we have Craig Lisk, and who will give us the perspective from the Medicare Payment Advisory Council on how Medicare sets prices. We have from the carrier perspective, Neil Kelsey, the Chief Actuary and VP, as well as Roberto Wachtelheimer, the acting president of Connecticut, and Pat Charmel, CEO of Griffin Hospital, one of our wonderful independent hospitals here in the state. And then we have a non-hospital provider perspective from Greg Shangold, who is president of Northeast Emergency Medicine Specialist, but is here representing the Connecticut State Medical Society. So we're going to do just the same way we had before. We're going to go through some presentations, and then we're going to turn it over to a discussion and question session. So if we have Craig Lisk on the phone.
Can you hear me?
Yeah, absolutely.
Can you see me? I'm on Zoom. So yeah, hopefully you can. And I'm gonna share my screen if that's okay. So anyways, I am hold on. Yes, here we go. So my name's Craig Lisk, and I am retired now from the Medicare payment. I was on the staff of the Medicare Payment Advisory Commission for 20 years and its predecessor commission, PROPAC, Prospective Payment Assessment Commission. So I work primarily on looking at hospital payment, post-acute care provider payment, and looking at the updates as well as quality of care and also graduate medical education. So with that, I am going to have a summary of what MedPAC looks at when it's updating and when it's making recommendations for updating and setting Medicare payment rates. And my focus today will be on hospitals. So one of the things to understand, first of all, is what MedPAC's role is in updating Medicare payments and who MedPAC is. It's Medicare Payment Advisory Commission. They're a 17-member Congressional Advisory Commission that makes recommendations to Congress on the Medicare program. And they make recommendations for hospitals, both inpatient, outpatient, physicians, and other health professional services, the different post-acute care providers, skilled nursing facilities, home health, inpatient rehab facilities, long-term care hospitals, hospices, and then other providers, including ASCs, ambulatory surgical centers, outpatient dialysis services. The commission makes recommendations for the Medicare Advantage program, as well as Medicare Part D. Now, one of the important things is what MedPAC has developed is a framework for assessing payment adequacy across all its different providers. And what it includes is basically looking at 4 main components: access to care, quality of care, access to capital, and Medicare payments and provider costs. So the commission looks at all of these things to see how the different providers are doing in determining what it believes is the appropriate payment rate for providers. And so what the commission is making recommendations for is updating recommendations for payment system base rates. And the base rates is the fundamental portion of what is determining provider payment levels. Now, MedPAC also makes recommendations on the distribution of payments, but the payment update for the base rate is the primary factor for determining the level of payments. So now I want to go on and look at focusing on hospitals. This slide shows the basic components of Medicare payments to hospitals. It includes the operating base payment, and that's what MedPAC is making recommendations for updating. But then there's adjustments for geographic factors, the area wage index being the primary factor for that, which it shows relative wages in different areas of the country by census, not census regions, but by the market areas. Adjustments, and then adjustments for case mix, which reflect the average relative cost of a particular diagnosis, which considers the principal diagnosis for procedures and whether there's complications or comorbidities in those cases. Then we move to policy adjustments that are part of the payment system. And for hospitals, we have the indirect medical education adjustment and disproportionate share payments and uncompensated care. And then there are adjustments for transfer paid cases, which if a case stays a full length of stay, it gets the full payment for a case. But then if it's a short stay case, the case is paid on a per diem. Now, particularly if it's a short stay case or it's a short stay case that goes to a post-acute care provider or to another hospital, it receives a per diem payment. And then, of course, we look at that's the payment for the case. If a case is extraordinarily high cost, the case can also receive high cost outlier payments. There are also other adjustments for quality incentive programs, for excess readmissions, the value-based payment payments, and hospital acquired condition payment penalty also on hospitals. Although in the last go around, only the readmission adjustment was made. So what I'm going to do now is go over what MedPAC looked at for hospitals and kind of the summary they did, this discussion they had last year on beneficiaries' access to care, quality of care, hospital access, and Medicare payments and costs for its update recommendation. So on beneficiary access care, which is the first component the commission considers, the commission found there was excess inpatient capacity in aggregate across hospitals. And in 2020 and 2021, there were fewer hospital closures than in the past, after actually reaching a peak in 2019. Some of this could have been due to help support from the federal support provided to hospitals during the pandemic, which may have helped reduce the hospital closures. Now, one of the big factors, though, in beneficiary access to care is hospital services per capita declined substantially. And that was in 2020, driven by a large drop in the spring in 2020, when we saw, because of the pandemic, a 40% decline in inpatient and 50% decline in outpatient services. Throughout the year, though, they still were down. And in 2021, they were down from previous periods. So hospital services declined. The commission, though, did find that hospitals with excess capacity do have a financial incentive to serve Medicare patients because they have a marginal profit around 5%. Now, quality of care, MedPAC concluded quality of care was difficult to assess because of the public health emergency and data limitations due to the public health emergency prevented them from accurately making an assessment. I mean, they did find mortality increased, readmissions declined slightly, and most patient experience measures declined slightly, but the public health emergency probably had a large impact on that. Now, hospitals' access to capital in 2020, they found that IPFS hospitals total, they include the total hospital margin, which measures payments and costs across all payers. They saw that declined in 2020, but remained strong in aggregate at 6.3%. Interestingly, though, in 2020, rural hospitals all payer total margins reached a record high. And that may have been due some to the input of targeted relief funds going to rural hospitals. The commission also tries to look forward a little bit more because they're working with data they have from the cost reports for looking at total margins, but they were looking at also in 2021 at the 6 largest hospital systems operating profits in late 2021 were exceeding pre-pandemic levels. So that was all a positive access indicator of hospitals' access to capital. So another factor, the fourth set of components of commission changes is looking at payments and costs. And here what we have is looking at the changes in payments and costs for IPPS hospitals. And what we show here is both the annual change in 2020, which was the most current year, and then what it was looking at before in 2016 to 2019 period. And as you can see, payments per stay actually increased substantially in 2020 by 8.7%, whereas the average change in 2016 to 2019 was 3.2%. The components here, the explanation of the components are here, but the important thing here, though, for hospitals in 2020 is IPPS cost per stay. It increased 12.6%, substantially higher than payments per stay. And the average, and this is substantially higher than the previous period from 2016 to 2019, when they increased by 2.8%. So if you look in the earlier period, 2016 to 2019, you see that actually EPS payments per stay actually increased faster than costs per stay. But unfortunately for the industry, cost per stay grew substantially higher than payments per stay. I have similar information here for outpatient PPS system. And again, we see a higher annual increase in payments in 2020 compared to the previous period, but costs, again, increasing substantially higher than payments. Again, in the earlier period, we were seeing payments increasing faster than cost for Medicare. Now, one of the factors the commission looks at here is the overall Medicare margin. And the overall Medicare margin refers to the aggregate margin across multiple hospital service lines, including inpatient, outpatient, swing bed, skilled nursing, as well as direct graduate medication uncompensated care payments. So in 2020, this chart shows aggregate overall Medicare margin, and MedPAC looked at it in 2 ways. They had them looking at it with including relief funds that they apportioned to Medicare and excluding relief funds. So if you include relief funds, you saw actually a slight increase in the overall Medicare margin, but it's still negative at minus 8.5%. But if you exclude the relief funds, it dropped to minus 12.6%, which is a historic low. Now, one of the other things that MedPAC looks at, though, is an important factor is they look at Medicare payments and hospital costs for the relatively efficient hospital. Relatively efficient hospitals, and they're defined over here, and they have both a risk adjusted, they're looking over a 4-year period where hospitals have to meet these criteria to be relatively efficient. They have to have risk adjusted mortality rates that were in the best 2/3 of all hospitals, risk adjusted readmission rates among the best 2/3 of all hospitals, standardized cost per inpatient stay are among the best 2/3 of all hospitals, and they have to have either risk adjusted mortality or standardized cost per stay that were among the best 1/3 of all hospitals. So that defines a relatively efficient hospital. They have to have that for every year over the 4-year period. And this defines about 15% of hospitals are relatively efficient. And if we look at this, the relatively efficient hospitals, we'll see their performance on quality metrics are higher than the other hospitals, and that their Medicare, their median margins are also better. But what's important here from the commission's perspective is we're seeing that the relatively efficient hospitals on overall Medicare margin have a margin that is slightly positive at 1% relative compared to the other hospitals, which is -6%. But it shows that hospitals are able to perform with Medicare payment, the efficient hospitals, and make a slight profit, which is an important factor when the commission is considering its update recommendations. Another factor that commission looks at is hospitals under fiscal pressure. And what they find is hospitals under fiscal pressure have lower all-payer margins, but higher Medicare margins. And so fiscal pressure is actually an important point in terms of how hospitals do under the payment system. So next, the commission considers the projected margin, and for 2022, because they're looking at 2020 data and they need to project the margin. And when they went to do the projection last year, they found that the 22 Medicare margin estimated would be about -10%, excluding relief funds, and -9% with relief funds. So that's a slight decrease from 2020. But they still found that the relatively efficient hospitals' median Medicare margin was estimated to be about 0%, excluding relief funds, and 1% with relief funds. So when we update when the payment rates are updated, the Medicare hospital market basket is the primary component of the update. And the market basket is a measure of input price inflation that CMS maintains. And it's measuring a fixed basket of goods and services that hospitals have. Its major components are compensation, which is the largest component, including wages and benefits. There's utilities, professional liability insurance, all these other things that go into the market basket and are weighted appropriately to look at this fixed basket of goods and how they change. What's interesting to note, though, is if we look at the period from 2018 to 2020, we have in this chart here, we have the forecast that's made at the time of the update, the blue bars, and then the orange bars, which is the most recent estimate. If you look back at the 2018 to 2020 period, we actually see the forecast at the time of the update was actually higher than what actual input price inflation hospitals faced was. In 2021, no, that changed as we started to see more inflation pressure through the later stages of our pandemic. And then in 2022, we see the forecast used at the time of the update was 2.7%, but the most recent forecast for this year for hospital input price inflation is at 5.5%. For 2023, the market basket used, which was put into the update, was 4.1%. And currently, we're estimating the market basket increase for 2024 will be 3.2%. So with that, we have then the current law updates, where the market basket this slide shows the current law updates that's MedPAC considered when making its update recommendation. And so when MedPAC was making its recommendation, they were anticipating the current law update would be 2%, although the inpatient hospitals would get 2.5%, outpatient hospitals would get 0.5%. When CMS made the updates, so the market basket forecast had changed, and that resulted in a net increase for inpatient hospitals of 4.3%, and then capital of 2.7% and outpatient of 3.7%. So MedPAC considered all these factors. Yes.
Ed, just a time check. I'm letting you know you got about 4 minutes left, okay?
And that should be about enough. So then this all leads to what MedPAC's recommendation was for its update recommendation. And their update recommendation for fiscal 2023, they said the Congress should update the 2022 Medicare base payment rate for acute care hospitals, the amount specified in current law. So when we go back to that previous slide, current law from the MedPAC's perspective is 2%, but what CMS did was 4.3%. And that's what consistent with what MedPAC did. Now, CMS is doing this by regulation. Congress could change it. Congress has not made any estimates to change the recommendation. I mean, to change the policies, but that could happen. So what I want to leave you here on the final slide is this is MedPAC's 2023 update recommendations across sectors. And then what we have is the actual update. So in inpatient, outpatient, and physicians, MedPAC was recommending current law updates. What actually happened was is shown there on the right in terms of what CMS did. Interestingly, though, on skilled nursing facilities, home health, inpatient rehab, MedPAC recommended reducing base payments by 5%. So they recommended a reduction in payments. For long-term care hospitals, they were recommending market basket minus productivity, which is equivalent to what is current law. That's the only recommendation that CMS actually has full discretion over in making a recommendation for updates. And then for hospitals, for hospice and ambulatory surgery centers, the commission recommended eliminating the update, but what they received is 3.8 and 3.8%. Again, for the post-acute care providers, they all received updates, even though MedPAC was recommending for 3 of them reductions. So with that, I'm happy to answer questions and participate in the discussion. I hope that was clear enough for you all. Thank you.
Yeah, thanks so much, Craig. We're going to hear from some of the industry perspective, and then we'll go to questions. Really appreciate the report. I will mention that for folks that don't know, MedPAC is part of the General Accounting Office, which is truly the most independent part of government. It's a creature of Congress. It's run by the Comptroller General, who was appointed to a 15-year term. And the reason it's so long is to ensure the independence. So it's interesting that MedPAC is located there. But with that, we're going to turn to carrier perspective. Second one of our carriers in Connecticut to participate in this forum. And I really appreciate and welcome Roberto Wachtelhausen and Neil Kelsey. Go ahead, guys. Thanks.
Okay. And are the slides loading? Okay. Okay. You can hear me all right? Okay. First, I just want to take this opportunity to thank the agencies for hosting this hearing today. Having sat here in other forums testifying in the past, I welcome this, the broader participation in as we try to address really what are complex and intertwined issues and not easy to solve. Next slide, please. Similar to a slide from AHIP that Miranda presented this morning, this is more recent data from Connecticut, but it shows the same overall concepts. How we spend as carriers every dollar that we take in premium, how that goes out in expenses. So you see here the biggest thing, about 84% of 84 cents on every dollar goes to pay for cover the cost of pharmacy and medical services for the members that we serve. One note is that under the Affordable Care Act, we must spend between 80 and 85 cents on medical services or provide rebates to customers. Hospital spending, both inpatient and outpatient, and retail pharmacy are the largest drivers of the health cost increases over the recent years. And prescription drug has grown disproportionately. If I had this slide from just 3 years ago, 4 years ago, that 22 cents was 18 cents. So a lot of growth in the prescription drug area. Important to note, I think that the 13 cents of every dollar in premium covers our internal expenses, which include taxes and assessments and fees. And the remainder, 3%, is contributed to surplus. That money is reinvested in our communities to improve our member experience, including reducing healthcare disparities in the communities that we serve. Next slide, please. As a chief actuary, I have to include math in the presentation. So this slide really shows that at its basic, simplest level, medical costs are driven by two things: utilization times the unit cost. Utilization is how members use medical and pharmacy services. Unit cost is the cost per service. And as we've mentioned earlier today, from other speakers, this is a fee for service approach. Every time one of our members encounters a physician or a pharmacy, they get charged the fee, and the customer or the insurance company picks that up. Each of these components is very complex, however. Utilization includes how many members seek medical services, as well as how many services are performed on each visit. Office visits, lab tests, all that is related to the number of services performed. Utilization is impacted by lifestyle and behavior. Unhealthy habits lead to illness and result in medical services, and that point was made at the first session this morning as well. Unit cost is the cost per service. We negotiate with providers. That unit cost varies by location and provider type. And between 2015 and 2019, hospital costs increased 37%. So while it's true that utilization is down, I think over that same period, 10%, as was noted this morning, the unit cost increased 37%. There has been a shift of certain infusions from inpatient to outpatient setting. That drives both a better patient experience and a lower cost. So the market basket of services is not static, and it changes over time. And finally, breakthrough medications, or the high cost pharmaceuticals, for which there are not lower cost, equally effective alternatives, that fueled an increase in pharmacy costs. If you can go to the next slide. The next couple of slides, I just want to touch briefly on provider contracting. Insurance companies and providers negotiate on the rates reimbursed for the services, the unit costs. The contracts are generally multi-year and include agreed upon annual increases for the duration of the contract. Hospital and provider consolidation has made negotiations more complex, I think, for both sides, both the providers and the insurance companies, in terms of reimbursement rates and also the duration of the contract. Each negotiation is unique, and it reflects the market dynamic and influences at that point in time. Both parties to the negotiation consider internal and external data points, which includes the state medical cost benchmarks that were referenced this morning. Over time, we have tried to move toward a more value-based discussion, reflecting outcomes and quality in addition to the number of services provided. So trying to put some value and quality into the negotiations and the rates. The overall goal is to reach a compromise which balances the provider needs for sufficient revenue to cover their costs, with the carrier goal of maintaining a robust network for its members within the constraints of the premium that they receive. As Cynthia from Kaiser pointed out this morning, insurance companies pay more than Medicare or Medicaid for the same services. I believe Paul pointed out this morning that they receive from Medicare about 88 cents of every dollar that they would need to cover their costs. And according to a RAND study, Connecticut health plans overall paid 206% of Medicare costs for their commercial rates and for inpatient services, and 239% of Medicare costs or Medicare payments for outpatient. Before I turn it over to Bert, I just wanted to reiterate that these are complex decisions in a complex situation, very, very much intertwined, a lot of stakeholders. And these are difficult decisions. As a society so far, we have determined that we want the best care as quickly as possible and without hassle. We want to do everything possible to improve health and extend life, and we want to cover everything. These decisions do have a cost, however. And it's important as we go forward that we balance the society needs and desires with how much we're willing to pay for healthcare. With that, I'll turn it over to Bert.
Thanks, Bert. You got about 3.5 minutes.
Easily done. So first, I want to echo Neil's sentiment. We're honored to be at the table and part of the conversation. I'm here today wearing two hats. As Ted said, I am acting president of Connecticut. I'm also the president of WellSpark Health, which is a Connecticut affiliate company. We're also based in Farmington. And at WellSpark, we sell well-being programs to employers, really focusing on what we call a biopsychosocial model of health. And it is that model that actually pulls together a lot of the things we heard here today around the need for social support. And if you could just move to the next slide. We're really focused on, next one, please. Next slide. There we go. So at WellSpark, we're really focused on lifestyle and behavior change and supporting people with this biopsychosocial model. And as you can see here, a very, very large percentage of healthcare costs are driven by lifestyle behaviors. So Neil spoke about utilization, but lifestyle, especially American lifestyle, high percentage of obesity in this country, it really is at the root of medical cost. So this really comes down to human behavior as a factor in premium setting. As a group gets sicker, they get older, they get sicker over time, perhaps. Yet the conversation today is all about sick care and how do you lower the cost when someone is sick? And we maintain that if you can work with someone on lifestyle and all the social support that we talk about, you can actually keep people out of the system and keep them on a good path of health as a way to control medical costs. On the topic of human behavior, let's pause for a second and remind ourselves that people buy insurance with their head, but they use it in the moment with their heart and with emotion. And that drives a lot of where they go for care in the moment. They may have all these tools at their disposal, but in the moment, they're headed to the emergency room if it's in the middle of the night. So again, these are social dynamics that impact the overall cost of care. We also think we, especially at WellSpark, believe that the reimbursement model for physicians needs to also contemplate lifestyle medicine. And right now, this is in what Lou was talking about, the need to move from volume to value. And we need to support the provider community in using food as medicine and practicing lifestyle medicine techniques so that you can back down perhaps some chronic disease without using the high cost of pharmaceuticals. So changing payment models, focusing on prevention, lifestyle medicine, and supporting people with community resources, again, and providers to deliver in more of a biopsychosocial model. So Ted, that's it from Connecticut. I'll pass it back to you.
Thanks so much, Bert and Neil, much appreciated. We're going to move on to a hospital perspective. We have two hospital CEOs today. On this panel is Pat Charmel, who is the CEO of Griffin Hospital. Go ahead, Pat.
Thank you, Ted, and thank you for the opportunity to participate today. And thank you to the agencies for sponsoring this. So if you would pull up the first slide. It's really the second slide. Next slide. There we go. So a number of speakers earlier today have alluded to a cost shift. And to understand healthcare financing, I put up this slide. Healthcare financing in the US has always been a system of cross subsidies, and you need to understand how they work and the impact that that's having on what the consumer pays, because I think what we're talking about today, for the most part, is the impact of healthcare costs that are having on consumers and what they're now having to pay out of pocket, which has been growing over time to the point that it really is unsustainable. So I've displayed this two ways, looking at enrollment in various types of health plans in Connecticut. So commercial insurance plans, by enrollment, you can see is the largest proportion of this pie. 55% of Connecticut residents are enrolled in commercial insurance. And then other pieces of the pie are traditional Medicare and then Medicare Advantage, the substitute for traditional Medicare run by commercial insurance companies, and then Medicaid. Right, so that's by enrollment. But as you can understand, the elderly use healthcare services. Those over 65 use healthcare services at a rate 4 times those under 65. So when you look at actual encounters with the healthcare system, the proportion shifts. So if you're a provider like Griffin, a hospital, our payments are based on those encounters, the people who come for services. So proportionally, you have fewer commercial under 65 coming, even though they make up more of the population enrolled, it's a smaller portion of the encounters. You look at Medicare and Medicare and Medicare Advantage together are about 33% of those encounters, and Medicaid 23%. So in aggregate, government payers based on encounters are paying for 56% of the care rendered and 37% by commercial payers. So you heard Craig talk about the fact that the Medicare program, if you take out relief funds during the last 2 years, is paying providers, hospitals, 87% of the actual cost of care. So the hospitals are delivering $1 worth of care and getting 87 cents. He also said that the cost of living increase that's been recommended for hospitals for the next year, which is the market basket adjustment, is 4.3%. So reducing those, increasing the payments that are now covering 88% of cost or 87% of cost by 4.3%. Now we have to ask ourselves, is that adequate? And you heard my colleagues talk earlier. Next slide, please. And I think it's 2 slides ahead. Next one. So this is not looking retrospectively. This is real-time data on hospital input costs. So looking at year over year through August, the most recent data available, and then over a 2-year period, what's happened with those input costs. I run a hospital, 60% of my operating costs are labor. So what's happening with labor costs? And I won't get all to all the reasons why labor costs are going up, but the reality is over a year over year, hospital labor costs have gone up 9%. Over 2 years, 16%. Remember, labor costs are 60% of the cost of an operation. Look at the other input cost. Non-labor expense, 4.2, over 2 years, 10%. And I don't need to go through each of the others. And now you have to ask yourselves, is that market basket adjustment from Medicare, the Medicare program that's paying hospitals 87 cents on the dollar, now wants to increase hospitals 4.3%, when 60% of our costs are going up 9%. If you look at over 2 years, 16%, and you could look at the other input costs. What will that result in? That 87 cents on a dollar is going to drop, right? It will be less than 87 cents because that market basket adjustment is not going to keep up with the increased cost. Okay, that's interesting academically. What are the consequences of that? Hold that thought. In addition to that 4.3, what Craig didn't mention is there's been previous federal legislation that's trying to reduce the US federal government's deficit. And they have imposed what they call sequester cuts on all departments within government. So over time, they have to reduce their spending. Well, hospitals are looking at a sequester cut. So that 4.3% cost of living increase is not going to be 4.3%. unless the federal government provides some relief from that deficit reduction legislation. So it could be that the average hospital like Griffin, instead of getting 4.3, might only get 2.7 or even 2, when our operating costs, at least for labor, are going up 9%, and overall operating costs are probably going up 6 or 7. So that means that 87 is going to, in terms of those costs go up, they're paying us 87 cents on the dollar becomes $1.10, and where that deficit is going to shrink. Okay, next slide. I really appreciate Roberta. I always like when people use the same slides that I use. Next one. Again. All right. So it is true that the US healthcare system, which is a system of cross subsidies, is a sick care system. And to be perverse, that the incentives in the current system are wait for people to get sick, the sicker the better. And then when they show up, do as much as you can for them. If you're a healthcare provider and get paid fee for service, frankly, those are the incentives. And that all worked for everybody, frankly. Right? It worked for hospitals because they got paid fee for service. It worked for insurance companies because they got to charge premium based on what we told them the cost was for that care, right? And the insurance company got to take 15% off the top of that for overhead and profit. So if the premium was going up, increased premiums were fine. But somebody had to pay those premiums, and it was the employer. And while the employer can afford them, it was okay, right? And then when the premium started to rise too much because we were asking the health plans for too much because we had a perverse sick care system, they pushed more onto the consumer or their employee, who now is paying 30% of their premium payroll deduction. And on top of that, they have a $3,000 deductible in copays, which they can't afford. So all of a sudden, the system of cross subsidies is no longer working. It's all coming crashing down. We were all part of the problem. Now we all have to be part of the solution. And I'm resisting the temptation to point at everybody else in the system, because eventually it's going to mean that I'm going to have to point back at myself or the hospital system as well. But these are the realities. So you heard that the stuff that we do that's too expensive, you all say we charge too much, right? The cost of healthcare. What we do, that's the bottom of the icon there. 20% is traditional healthcare. So
Pat,
all of the money we spend in the US.
2 minutes.
Yes. All the money we spend on healthcare in the US is only impacting the health of individuals by 20%. It's the everything else. It's health behaviors and all those social factors, right? So if you're saying move away from the sick care system, wait for people to get sick, the sicker the better, and to do a bunch of stuff to them, let's move to value. Value means we have to spend money on all of those other things. We have to influence, you heard Lou talk about engagement, influence behaviors, deal with those social factors, and all of those social factors are totally out of control post-pandemic. So the question is, where are the dollars coming to invest in the capabilities to manage those health behaviors and those social issues, which, by the way, hospitals don't touch now. We identify individuals, refer them to community-based agencies to address their social factors. And those agencies say, thank you for the referrals. We have no resources. How's about giving us some of your resources? And we say, what? We don't really have enough resources to pay for the 20% that we do, which is because Medicare is only paying us 87 cents on a dollar and our cost of living increases isn't going up as much. All right, next slide. Indulge me. I'll talk as fast as I can. Here are those social factors. You heard about the diaper program. Griffin actually started that program here in Connecticut and has been doing it for more than 10 years. We're buying produce and protein for local food banks because we know that adequate nutrition leads to health. Right now, those food banks are relying on donation and they're getting unhealthy food. So the poor and working poor are going to food banks and getting non-nutritious food and getting sick as a result. We have to invest money in making sure if they don't have adequate food and we're going to address food security, we do it with healthy food. Next slide. Here's the dilemma. Many communities are under-resourced. You have a growing number of Connecticut residents that are either in poverty or who are working poor. I actually have a hospital that's in the lower Naugatuck River Valley. The two towns that we sit in between, of 50% of the people who live in those towns don't earn enough to meet their basic living needs. 50% of the population in those two towns don't earn enough to meet their basic living needs. So are they going to live healthy lifestyles in safe homes and eat nutritious food and afford their medications? No. Next. So the US spends more on that 20% at the bottom of the little man that I showed you. We spend twice as much as the average of every industrialized country in the United States on that 20%. We don't get better outcomes for that. Next slide. If you look at what the US spends on social services, the top of that man, and medical care, combined, we're pretty good. We're not the best, but you could see the blue bar, which is traditional healthcare spending, is larger than anybody else's. The red's pretty small. Next slide, please. We spend less on social service spending as a proportion of total healthcare spending, which is that traditional medical and social together, than any other industrialized country in the world. We spend less on social service spending. And if you're saying that has more influence on the health of the population than what we do in medical care, we've got to change that. The problem is, where's that money going to come from? Next slide. Last thing, and then I'll address the rest later. We talked about Medicare paying 87 cents on the dollar, which is going to get worse because the market basket adjustment, the increase in our allowance, isn't going to be adequate to cover our increased cost. Remember that piece of the pie that I showed you at the beginning. 23% of our encounters are Medicaid in the state. Medicaid in 2019 was paying 43 out of 51 states. It's the states in DC. 43rd out of 51 in terms of what they pay as a percentage of cost. It's only 74%. Go to the next slide, and this is the last one. We're now 48th out of 51. So our Medicaid program is paying hospitals rates that are 68 cents on the dollar. 68 cents on the dollar. So if you look at that government pay in the pie chart that I showed you, which is more than 50% of the counters, you have Medicare that's paying 87%, Medicaid that's paying 68 cents on the dollar. That's not covering costs which are going up at unprecedented rates. So what we're doing is shifting it to Lou. And I'm calling Lou up and say, Lou, you got to raise my commercial insurance rates to pay for what those two other payers aren't paying. And look at what my operating costs are, how they're going up. And he'll say, Pat, those costs are transitory. I can't give you an increase. The reality is hospitals are not going to be able to continue to operate unless we fix this system of cross subsidies and together work on shifting our attention from traditional Medicare, medical care to those two other portions that we talked about: health behaviors, lifestyle, and social determinants. Thank you for the extra 2 minutes, Paul. I
Pat,
appreciate
thanks
that.
so much. I appreciate that and look forward to discussing the social spending and other issues with you as we go on. So we wanted to have a non-hospital provider perspective. Dr. Shangold, Greg Shangold, is here with us. He is a physician. I do want to be respectful that there are other non-hospital providers. We're aware of that, but we couldn't fit everybody in. But Greg Shangold, who is representing the Connecticut State Medical Society, go ahead.
Thank you, Ted. And once again, thank you for having this forum to discuss this important topic and having us as a participant. So as Ted said, I'm actually a past president of the Connecticut State Medical Society. I'm also a managing partner for Connecticut's only independent democratic emergency medicine group. We take care of about 150,000 patients a year of the 1.7 million emergency department visits within Connecticut a year. And since we've talked a lot about international, I guess personally, my wife's from Belgium, so I've had to deal with a lot of Belgian. Well, the game's going on now, so that just to show my individual sacrifice. But I have had to deal with those, and let me tell you, it's we see the graphs, but every story I've been involved with from Belgium is not what we should be emulating. So we have the perspective of both running as a small business, because that's what we do, and working within this complex healthcare system. And it really is complex, but it's also rather simple in the sense that you just need to create more revenue than your expenses into running it. And probably even more so for our group than the hospitals, our biggest expense is labor costs. We've been throwing around a lot of terms today, and I think it's important just to make sure that we talk about costs and we all have the same definitions, because there's charges out there and everyone puts a charge that, but that's not being paid anywhere. So these are being transparent and you put them out there, but no one actually pays the charges. There's actually the cost of actually doing the business, what actually the cost to provide. And then there's another piece, which are these payments. And so I think Pat made a good example of how much is just fixed. Medicaid, Medicare, we have very little input into those payments. And for emergency medicine, it's the same numbers. It's 65% are Medicare, Medicaid, or self-pay. And the cost shift is just what society has decided to take care of that. As far as how we get those commercial rates, insurers with providers really give it a take it or leave it contract. There's not much negotiation at all. If you want to be part of their network, they say this is your contract. And once you have that established, there may be a 1-2% increase each year. But as we just talked about, that doesn't cover for inflation and what our labor costs are. So, having adequate networks would certainly maybe have some incentive to make sure that there were fair contracts that were there. And if we don't reach a contract, both the federal government and the state of Connecticut have passed laws, at least for many specialties, on what that exposure is for the patient. But unfortunately, many of these laws are heavily tilted in the favor of insurance companies, and they still provide underpayments to physicians. So, as we've said before, we really have to have this commercial insurance to compensate for the underpayments or non-payments in many cases of Medicare, and the uninsured. So for Medicaid, emergency physicians have had the same rate. So this isn't government speak of like not having an increase in the increase. It's been flat since 2011. Orthopedics has been flat since 2008. So when you look at since 2011 to today, there's been a 32% increase, or 32% of CPI for inflation, and Medicaid's been flat. Yet we still have to provide those services to those patients. And this is why many providers actually do not take care of Medicaid patients. And then that just means they don't have access to care. The people that are low income, they become sicker, and then they show up for care that's even more expensive than that. In Medicare, I think we've talked about this, but I don't have slides, but I can show this. The black line's physicians as far as Medicare inflation, and this is everybody else. So whereas we were talking about, and I think it was sort of hidden in there, but in Craig's presentation, physicians are getting a 4.5% decrease this year. We were the only negative ones up there. And that's 4.5%. We've only had an 11% increase since 2001. So just about half of the increase since 2001 is right now threatened to be taken away. If you look at it from another perspective, since this graph here, same sort of graph, right? Physicians flat, inflation going up. There's been a 53% reduction in Medicare. Now, when insurance companies do come and talk to doctors, they always talk about giving you a percentage of Medicare. People from Connecticut mentioned that 206%, 238%. Well, if Medicare isn't even paying for costs, then talking about keeping, at least from the physician perspective, as a percentage of Medicare, just parts into that inflation and getting less money to pay for costs. Additionally, from the ever increasing high deductible health plans, as well as other patient responsibility tools such as copays and coinsurance, we don't collect the 238% or 206% of Medicare. We only collect half of it because patients do not have the money to pay for these things. They can't fund their HSAs if they do have HSAs. And as we've talked about the cost of healthcare, right now, the physicians, eat that cost. There's nothing we can do about it. So Connecticut in 2019, and everything now is defined as pre-COVID or post-COVID, right? So in the pre-COVID timeframe, the legislature passed, we were talking about high deductibles and they got a task force together. And we came out with many ideas, and that's all been tabled. And we're going on 3 years now where we talked about all this. So I'm not going to rehash all of that, but there are definitely suggestions in there to help solve these high deductible health plans, including value-based purchasing and transferring some of the risk of now physicians eating all the patient responsibility, which interferes with patient care and thus increases patient care because patients do not want to go back to their doctor where they can't afford those bills. Two things we haven't talked about at all today is the cost of medical education. Doctors, it costs $300,000 for your undergraduate, another $300,000 for medical school. Then you go into residency for 3, 5, 6 years where you're paid basically minimum wage. And then you have to pay this back. That has to be funded. So when we look at all the Europeans, they don't have a $600,000, $700,000 cost of medical education. So we haven't talked about that at all today. But these
Greg, 2 minutes.
These payments go to trying to attract physicians to Connecticut. Connecticut is one of the worst states in the nation in regards to retaining those residents in which we train. So Yale, Hartford, Quinnipiac, we train these residents, and there's some other hospitals that have residency programs. And then when they're finished, they leave the state of Connecticut. So that's another part about it. And then the other part we haven't talked about, and I know it's always a third rail in politics, but the costs of defensive medicine. There's studies now that $300 billion can be added to the healthcare costs by defensive medicine. I know personally, as a practicing physician, every patient I see, probably I generate costs because of the fear of being sued. And some studies have it as 3% with even up to 10%. So there's a lot of different ways to look at it. And Connecticut has these rapidly escalating verdicts that are specific to here. 2 more parts, and I think I'll be in there in 10 minutes. One, there's been a recent study that shows a lot of non-physicians who are making medical decisions actually increase the cost of care and increase that utilization. So although on one, the unit cost might be less expensive of having APRNs and PAs provide care, when we do not have physician-led teams, they actually use resources at a higher rate. And there's some studies that show that. And lastly, I would say that the part I can't get around and doing the math is that the rate increases for insurance companies at 13%, 21%, whatever that ask is, and then physicians only getting 1 or 2% increasing each year. And then you match that up with the profits that the insurance companies are making compared to all the physician groups, which cannot afford to stay in business because of the regulations and providing more resources to do things such as pre-authorization. That math doesn't match up because physicians are going out of business. They're looking to sell to hospital systems or to private equity. They can't make these systems match. And all of that is reducing competition. So I think I've gone over a lot of this stuff here. But really the physicians, I think, are sort of the piece of the puzzle that's left, but they are the backbone. And they're the ones that have been on the front lines along with the nurses and other people taking care of the healthcare. And we can see what happens if that safety net is not there in Connecticut. Thank you very much and look forward to the rest of the discussion.
Yeah, thank you, Dr. Shangold. So now I'm going to throw it open to the panel. If you have a question for a co-panelist, that includes Craig Lisk, formerly of MedPAC, who is on the line with us. Does anybody have a question they want to get answered? Please go ahead. If not, we can start with the moderators. I will go ahead and ask Pat Charmel basically the same question that I asked the last panel, which is there's a lot of variation in the cost of hospital services between different hospitals, sometimes between hospitals that are just a couple miles away. I think figures I saw in the litigation involving St. Francis and Hartford Healthcare, right close to each other, was colonoscopies. I believe at one place it was 1,700, the other place was about 4,000, which is more than twice. What accounts for that, Mr. Charmel, in terms of why across town a consumer, and often, of course, if you got a $6,000, $10,000 family deductible, you, the consumer, are going to be hit with that cost. To what do you attribute that? Because it's from the consumer standpoint, that's a large disparity in the same town. It doesn't make a lot of sense. So shed some light on that.
Sure. Thanks for that question. So want to make a distinction between cost and the price that the consumer pays. And the price that the consumer pays if they have commercial insurance is the contracted rate that the provider, let's say the hospital, has with the various insurance companies. So let's talk about cost first. The cost structure of Connecticut hospitals, and there are 28, differs. They have different service mixes. They have different payer mixes, meaning the population that they serve. One could have more Medicaid, and one can, and another hospital, say in Lower Fairfield County, may have lower Medicaid. So in terms of this whole cost shift that we're talking about, that is going to vary from hospital to hospital. Some could offer tertiary and quaternary services. Those are expensive, so that could drive up their operating costs. So there is difference in operating costs, and that can translate down to the unit cost difference. But then there are these differences in the contracted commercial rate. And Ted, you're right. The rates vary dramatically from hospital to hospital. If you look at a standardized inpatient stay at a hospital, the contracted rate on average in Connecticut for a commercial insurer varies from the lowest being 2.5 times less than what the highest hospital in the state gets paid. So again, more than 2 to 1 from highest to lowest. Now, there is new federal legislation that was passed a couple of years ago that requires hospitals to publish their rates. And that is now affecting insurers who now have to publish their contracted rates in a consumer-friendly manner. So now the consumer and their employer who's buying their health insurance can see that maybe Griffin is getting paid half of what another hospital's paid for the same service. And those same sites can actually tell you whether we produce better outcomes and a better patient experience. So what's going to happen, I think, we talk about consumerism in healthcare and value-based care. We have to make sure that we inform consumers and we design insurance company products that incentivize consumers to seek that high value care. The state of Connecticut has been a leader in that with the state employee health plan. They're actually providing cash incentives to state employees and their dependents to use high value providers. And those are large cash incentives. Frankly, other employers have been a little timid about that. I'm not sure why. Now, again, if I start to lose business, I'm the 2.5 higher than the lowest because consumers start to move from one to the other. I might be calling Anthem or Connecticut and say, lower my rates because I'm losing business. Because consumers have figured out that there's a hospital that gets paid less and I'm paying out of pocket, so I'm going to go there.
I'll just note that your hospital is noted for often being less expensive, and thank you for providing that.
I know that's a blessing and a curse.
But anyway, it's something to be proud of, I think. I want to turn it over to Commissioner Mays has a question.
Thank you, Ted. And my question actually piggybacks on Ted's and relates to a conversation Ted and I had a few minutes ago. And Ted, it's for you. Sorry, I got you on the hot seat here today. But you're the hospital guy. What I'm really looking for is your opinion more than anything else, because we were thinking as we look at different payer models.
Yeah.
You look at the Maryland model, which is an all-payer model. You've got a global budget. Everybody gets paid, whether it's Medicare, Medicaid, self-pay, commercial insurance. It's the same price for that particular service. And it seems, the Center for Medicare and Medicaid Innovation has praised it for reducing costs, bending the cost curve. How would you feel about a model like this? Now, I know it's not something that we could just simply adopt whole as it is, But do you think something like that could work in Connecticut, or how would we have to modify it to make it work if you think there's a possibility of it working?
Yeah, and I think when we say that that controls cost, so it definitely will kind of standardize pricing, meaning what the consumer would pay. So you wouldn't have that high to low, 2.5 to 1 to 1. And because a hospital may, under that system, if you're one of those hospitals that's currently getting the 2.5 higher than the lowest, and you start to get paid less, you're going to be forced to reduce your operating costs, if you can, to get down to that new standardized rate. Frankly, the state employee health plan, if you remember, a couple of years ago in the legislature started to talk about something called reference pricing, right? So if you say that the highest hospital in the state gets paid $2,500 for something and the lowest 1,000, well, maybe the state sets the reference price at 1,800. The guy that's paying 1,000 thinks that's great because he goes from 1,000 to 1,800. The guy that's at 25 is not liking the 18. So I think it will accomplish certain things, but it will cause tremendous disruption. And as I said, some hospitals do have higher operating cost structure for good reason in some cases, and others maybe it's due to inefficiency. But those are the things that you would have to confront.
If I could just get one quick follow-up, from what I'm hearing from you, if there were.
I'm
such-
hedging a little because I have to be
Understood.
careful.
And I'm not, but I'm really trying to find out for myself here. If we could do that, so each hospital, the individual circumstances are taken into account as the pricing is developed, would that be something that would be more reasonable, more achievable here, do you think?
Yeah, I think as an industry and, my colleagues from the Hospital Association are here and, if you would invite them up, because I think it's an important, I think we as an industry and me personally would be willing to explore other payment models. But I think they would have to take into account some of the things that we just talked about, right? We tend to focus on traditional medical care. How do we rationalize pricing between high to low? But we're ignoring the things that I was talking about, Roberta talked about, and even Lou was talking about when he talked about value-based care. But we're really going to bend the cost curve. We have to change the kinds of things that we pay for. How do we spend our limited resources to improve the health of the population? So any model that we come up with has to look both at traditional medical care and those social determinant inputs, which nobody wants to own, right? Thanks.
I will just, one quick comment is, there are lots of fee-for-service countries out there that are delivering quality healthcare at a fraction of our cost. So it is possible to do. Kim, do you have anything? Paul, you want to go ahead?
Just a quick question, and it's really for Pat and Dr. Labor cost structure.
Yeah.
In Connecticut. You talked about it being 50 to 60%. Doctor, you talked about it even being a greater percentage. Are we unique in Connecticut with the level that our labor costs in the medical field increases year over year? I think, Pat, you mentioned 9% a year and then 16%
Over 2 years.
over 2 years.
In the latest period.
Yeah. Are we unique in that perspective? Do we start with our labor costs here and the rest of the country starts with their labor cost here and there's equal movement up in increases in labor costs? How does that work?
Yeah. So the Medicare program, and Craig could probably address this. So we all get a base rate, and then there's a geographic wage adjustment that gets added, and it's by metropolitan area. They look all across the country and come up with an inflator based on the cost of living and the wages that are prevailing in each of those metropolitan areas. And Connecticut has a high prevailing wage, not only for healthcare employees, but others. Cost of living in Connecticut is high, but we've got a problem demographically in Connecticut. The working age population in Connecticut is shrinking. And the elderly is growing, and the old elderly is growing faster, and the poor old elderly are growing faster than that. And so we've got a shrinking pool of labor trying to serve in healthcare a greater demand, which is driving up healthcare costs. That's another fundamental problem. The problem with all of this, there's no simple fix. So there's probably another 25 people we need to invite to this table to have conversations about that. But there is a lot in terms of expanding the healthcare workforce. There's a pool of individuals in Connecticut that don't have opportunity. And I think working together with the state and the provider community, we can create opportunity for individuals to improve economic benefit and improve the workforce to care. So it'll dampen this increase. And we have a limited pool. It's supply and demand. Frankly, the various professions are in a pretty good position to demand higher wages because there just aren't enough of them.
So I think we're going to wrap up with just one more question I have for Dr. Shangold. You were mentioning that the physician reimbursement rates have been flat for a number of time from some of the major payers. Does this contribute to why practices wind up getting acquired by larger systems?
The business calculation of those two inputs, right? The cost of labor plus your individual costs. When it stops making sense, you look for options, and that might be venture capital money. It might be saying, I'm done with the business of medicine and I want to turn it over, to an employer. And I think more of the younger doctors coming out are looking for that. I mean, this conversion, I think it's over 70% that is there now or not in private practice. But it's not all just the lack of reimbursement. As I said, there's the younger doctors want to come out for and have all these loans paid for. There are programs where hospitals, and if you work for a 501c3, but private physician groups cannot compete with that. So there's no incentive there. And then it's choosing to come to Connecticut. Connecticut is not a place where doctors choose to come because of the malpractice environment. And there are salaries, just to answer Paul's question, our salaries are not the top in the country. They're not the bottom of the country. But when you look at them relative to the cost of living of other places, that delta that's in there is not as there. So if you look at the external pressures of the buying real estate, buying a house, your cost of education, the other regulatory pressures, I think you end up saying, why do I want to go into sort of private practice? And I can tell you, our group and my partners, we spend a lot of time on the non-medicine components of trying to keep our business alive. And the 68 people we have between physicians and PAs, we have 68 of us. And, there's a responsibility there to make sure. And then you throw in burnout, and that's a whole other separate piece.
Thank you to the panel. Thank you to Mr. Lisk. Really appreciate the input. So we're at 12:23. I don't know what we want to do. Okay, folks, it's 12:24 now. We're going to try to have we're going to truncate the lunch break to a 15-minute break. Let's try to get back here at 12:40 for the third panel. Thanks.
figuring out the economics around.
Are we ready? Yes? Okay. All right. Hello, good afternoon. We're going back on the recording. We are here now and I'll be running the third panel, which is a discussion about other factors in setting prices. And today we have Lauren Adler, Associate Director, USC Brookling Schaefer Institute for Health Policy, discussing the public-private cost shift literature review for 15 minutes. Then we have Dr. Peter Bach, the Chief Medical Officer, Delphi Diagnostics, former Director of the Center for Health Policy, Memorial Sloan Kettering Cancer Center, discussing drug pricing, innovation, and other considerations, 15 minutes. We have Michael Baylett, President of Baylett Health, as well as a contractor for OHS to implement the cost growth initiative. And we have Adney Rakatonia, I'm sorry if I did not pronounce that very well, from the National Academy of State Health Policy, NASHP. And we have Marilyn Bartlett, the Senior Policy Fellow from the National Academy of State Health Policy, NASHP. She will be discussing the Connecticut cost drivers and the NASHP hospital break-even analysis, 45 minutes. And last but not least, Kurt Barwis, our CEO for Bristol Hospital for 15 minutes, and then our moderators, questions and discussion. So we can start with Lauren Adler. Are you on the line?
Yes, I am.
Okay, wonderful, Lauren. Thank you.
Let me share my slides here to start with. All right, are the slides sharing now for everyone?
Absolutely.
Yes.
All right, perfect. Great. So thank you for having me again. Yes, my name is Lauren Adler. I work at the USC Brookings Schaefer Initiative, based at the Brookings Institution, which is a nonprofit, nonpartisan research institution in Washington, D.C., or a think tank. So I do a fair amount of research on various health economics topics, and sort of do technical assistance work for policymakers. I'm here just sort of talking about this cost shifting question that's come up a fair amount in the earlier portion of the day here, and trying to kind of separate fact from fiction in terms of what we actually know about this question, as it's actually been studied fairly a fair amount at this point in time. So I think sometimes there's sort of a confusion of what we're actually thinking about here. So in one sense, yes, it is certainly the case that we see higher prices, that commercial payers, private payers are paying more for hospital services than Medicare. So right, this graph here is just showing that commercial payers are paying something nearly 3 times what Medicare pays for outpatient hospital visits, and nearly 2 times what Medicare pays for inpatient hospital visits. And it's less of a discrepancy for physician services, and it's only 133% of what Medicare pays. But right, so in a static sense, yes, it is true that that Medicare is paying less than these private payers are paying. But really, the cost shifting argument that I've heard largely today is really a causal claim being made that for in the hospital context here, which is mainly where it comes up, that hospitals are charging private payers more in response to low public payer payments. So it is, oh, my Medicare update is going to be slow this year, so I'm going to have to come back to the I'm going to have to go to the insurance company and ask for more money this time around. That is a little bit harder to make sense of. So I think there's some intuitive appeal to this statement, and obviously it's gotten made forever. Most hospital administrators will tell you this is definitely what happens. But I think there's sort of a fundamental issue here, if you try to think about the theory behind this, is just, right, if hospitals could raise prices on private payers above what they're getting paid today, why aren't they already doing this? Right, so fundamentally, this sort of theory of cost shifting is only possible if hospitals aren't trying to maximize profits today. And right, a lot of hospitals we're talking about are big public companies here, but even in even in most cases, are trying to make money at the end of the day, or trying to pay the bills. It would seem odd that they're purposely leaving money on the table today, and that only in that context would they come back, and now only because now I'm having tighter payment rates for Medicare. Now I got to all of a sudden try to use my leverage that I already had. I will say, right, in the hospital context, we do have for-profit hospitals and nonprofit hospitals. Although, right, we have a fair bit of evidence at this point that nonprofit hospitals act pretty similarly to for-profits in most ways. But, so I've sort of explained why I think the theory of cost shifting makes it seem pretty unlikely. But fundamentally, this is an empirical question, right? There's a lot of data on this. So I think what I'm going to focus on here is, what does the empirical literature actually say about this question? And on that front, that's one where we consistently see that all of the empirical literature here finds zero evidence that this hospital cost shifting phenomenon actually happens in practice. So probably the seminal paper on this is Chapin White, who was a researcher at Rand at the time, looked at what happened looking at how Medicare prices changed from 1995 to 2009, and basically looked at the hospitals that saw slower increases in Medicare prices. So, sort of saw reductions in Medicare prices relative to other hospitals. What happened to what private insurers or commercial insurers paid them? And actually found, not only did they find no evidence of cost shifting, but they found the opposite occurred. So they found that when Medicare prices went down or grew more slowly, that private insurer prices also grew more slowly, such that if you were to think about it, it's basically a 10% reduction in Medicare prices actually led to a reduction in how much commercial insurers were paying by between 3 and 8%. And while that may seem a little odd on its face, the basic idea here is, right, private insurers are still paying a lot more, on average for the care. So if I'm a hospital and I'm now getting paid less by Medicare, it's now even more important for me to get sort of a higher share of commercial paid patients in the door. So I'm more willing in negotiations with insurance companies to say, okay, I'll take a little bit of lower price if you steer more patients to my hospital to sort of get more of that private insurer share in. But again, right, really no evidence that, right, the cost shifting theory would say when Medicare prices go down, that you would actually see higher private insurer prices. But right here, we see the opposite. There's another big paper by Chapin White and Vivian Wu, which finds basically the same thing, but just looking at how Medicare price cuts affect just the sort of revenue of the hospital. And sort of with a similar idea finds that the Medicare price cuts that hospitals saw were actually associated with larger revenue declines than could be explained by that direct Medicare price effect. And that sort of idea here is that sort of implies that there presumably were price reductions from private insurers as well. And what we saw here in their paper, the nice part here is they went into the mechanisms. They went, okay, yes, what happens when hospitals see lower Medicare prices? Was interesting. They even broke this out by nonprofits and for-profits, and interestingly found that nonprofit hospitals responded one for one by actually just reducing their operating expenses. So I think we've been talking a lot about today as if operating expenses are almost fixed, but there is obviously some room to cut down on the cost side of the equation, and that's what we saw. I think there's research from MedPAC that estimates that really only about 20% of a hospital's costs are fixed in the short run. As folks were talking about earlier, most are labor costs, which obviously can be changed in the shorter run. For-profit hospitals, interestingly, with the lower Medicare prices, actually just saw lower profits. Just to explain this a little bit, this is the sort of key graph from that first paper I was talking about in 2013, and this is just sort of showing you what was sort of being found here. Basically, right, the hospital, the dots here are sort of what the Medicare growth rate over this 1995 to 2009 period was, along with what the sort of growth in private insurer prices was. And you can see the sort of hospitals on the low end of Medicare price growth also saw lower private insurer price growth. I think it's important also to just look at this question of, even just from a cross-sectional perspective. This graph isn't really trying to, prove a causal story or anything, but in a recent report by the Congressional Budget Office, who's sort of the neutral scorekeeper that Congress uses in the federal government, they tried to look at just what is the actual cross-sectional relationship between what share of a hospital's discharges come from Medicare and Medicaid, and what is the average commercial price that they're getting, from commercial payers. And even this, you see, they do find a slight relationship here, but a very minor relationship, basically that, hospitals that have a higher share of public payer patients are really only seeing marginally higher prices from private payers on average, which is sort of right. What the cost shifting argument here would be, okay, when I have, when I've got to have to see a ton of Medicare and Medicaid patients, I've really got to stick it to the commercial plans to sort of make up for that. But in reality, the sort of payer mix of a hospital only explains about 0.4% of the variation that we see here in the sort of private sector prices here. So it's really a pretty minor part of the story. And I think I want to take a step back at this point just to sort of talk about something that was in the MedPAC presentation earlier as well. Right, that we have a fair amount of evidence that hospitals, that hospitals with more public payer patients actually have lower costs as well. So hospitals that are under more financial pressure because they see more public payer patients are able to come in and be more efficient on the cost side. So for my sort of econ speak, right, the costs and the prices are somewhat endogenous in the sense that, look, if I'm hospital, I have high market power. It's easier for me to pass costs on to employers and insurers. So effectively, if I'm able to get just super high prices, there's less incentive for me to reduce my operating costs. And we at least see that relationship. I will say, to be in fairness here, there's also evidence that hospitals with more public payer patients are more likely to be under financial pressure, close or be acquired. So it can still be the case. Like, nothing I'm saying here is sort of saying that Medicare prices are the right price in some sense. It is just that really trying to think about the actual, is there any sort of causal relationship here? And on this one, I think it's important to think about, this sort of cost shifting theory here is very convenient, right? It is both used to justify, this is the only reason why we charge so much money to privately insured patients / employers. And it's also used in sort of the federal and state debates over, should we increase Medicare or Medicaid prices, or inversely not decrease them, at least, as is often the case. Right. And I think my main point here is, if governments were to all of a sudden increase Medicare and Medicaid prices, certainly hospitals would make more profits. But it seems pretty far-fetched that commercial prices would all of a sudden go down if all of a sudden Medicare and Medicaid started paying more money here. Lastly, I sort of just want to touch on that we do see the very similar story in the prescription drug context. So I've been talking about all on the hospital side of things, but this came up a lot in the recent debate over the Inflation Reduction Act and all this sort of swirling talk about drug price negotiation and drug price regulation. Look, if Medicare comes in and just pays a lot less for prescription drugs, that's really just going to say, that's going to cost shift. That's going to just, squeeze one end of the balloon. And all of a sudden, then commercial payers are going to have to pay a lot more for drugs. And I just sort of want to note that story to me is similarly far-fetched, and actually probably a little bit more strained when you're talking about almost exclusively large for-profit drug manufacturers. And this graph is just from a paper I wrote with Ben Ippolito at the American Enterprise Institute, which basically just looks at, okay, what happens when, so this is often the case that sort of the generic equivalent or a biosimilar drug enters in Europe before it enters in US. And it basically, the sort of brand drug there or biologic, really their profits go down, the revenue goes down very quickly. And this, so the idea would be, okay, when you lose all your revenue in Europe, are you able to sort of make that up on the US side of the equation? And we really see no evidence of that. Basically, when the drug sort of loses all their revenue in Europe, we see sort of the US revenue and profit trends sort of just keep on trucking here. And then just since we've been sort of talking about that, to close here, right, we've been talking about how the cost shifting idea here really isn't why prices are high in private insurance. This is more just to kind of tee up some of the next parts of the conversation, is just, why are prices high in private insurance? Certainly limited competition is part of it. in most parts of the country. Actually, Connecticut actually is a little bit less in this boat, but there often is very limited competition among hospitals. This has been an industry that's seen a ton of consolidation, mergers and acquisitions over the last 2 decades. There's sort of fewer hospitals that are competing against each other, the higher prices that patients are going to pay. And even when there are a number of hospitals, it's often the case that for most employer plans, you are really having every hospital in your market in network. So even if there are a few hospitals, there still may be limited competition actually between them. Right. There's also just a high consumer value that, the consumers place on a choice of provider, especially in large employer plans. Consumers seem to value having access to, sort of every hospital. There's also, right, there's a number of public policies that limit insurer leverage. A lot of these are actually at the state level. So all sort of certificate of need policies that make it harder to build new hospitals. COPAs, certificates of public advantage, that basically shield hospitals from federal antitrust regulation, and then just sort of any willing provider laws that sort of really undermine insurers' leverage in negotiating prices. And then lastly, this one's a little more speculative, but there probably is sort of some level of greater public sympathy for providers, doctors, and hospitals than insurers, I think, understandably, but that presumably plays some role, because sometimes this honestly gets played out in the press when there's a big battle between an insurance company and a hospital. And I think sort of typically you'll see, to the extent that the public sympathy falls on the hospital side of the equation, an insurer may feel, or employer may feel, forced to kind of pay up to keep that hospital in network. And on that, I will close, and I'll stick around obviously for the Q&A, and happy to answer any questions that folks will have then.
Thank you so much, Lauren, for that presentation. Dr. Bach?
Yes, thank you for having me. I'm going to talk about a somewhat different topic, but it relates to Lauren's comments regarding pricing in the pharmaceutical setting. I'm going to try, I was going to share my screen, if that's okay. It's the same deck.
Yes, that's fine.
Okay, great. Let me just check that you can see my slides. Yep, I can see them perfect. Great. All right, so I'd like to think about pharmaceuticals in terms of a marketplace where incentives are present, and those incentives are designed to achieve certain public goals. And the reason you can sort of be confident that that's a reasonable formulation is that ultimately, in all senses of the word, it is the public paying for drugs. But what I really want to focus on is it's actually the marketplace itself that was designed by the public. It's not in any sense a natural market. Most drugs cost very, very little to manufacture. And so it is the creation of artificial monopolies and things like that that allow the market to function in any way. So put another way, the US and the rest of the world by extension's pharmaceutical market being characterized by several features. The first is that it is almost entirely artificial through government policy, and I'm going to talk about that. And it is free in somewhat unusual ways, given that it is a creation of government and policy. It is free because companies can select what they develop and how much they charge. And given that freedom, policies that are designed to then direct the market in particular ways through incentives and penalties can work extremely well, but they don't necessarily achieve aims when they are misguided. The central element of this market, and I'm about to show you this graphically as well, is a time-limited period of unconstrained pricing. This is in the US. And then post that period, there is intended again to have a market type force of competition that drives down prices. And I'll tell you in advance that the pharmaceutical industry, particularly, as well as legions of people who consult for them, have come up with lots of fancy solutions to this problem, but very few actually solve the key problem I'm going to try and highlight. And if you want to consider it over a longer time period, it's fair to say that this marketplace is increasingly inefficient in producing what we kind of collectively would like to see it produce on every margin. And I'm going to explain what I mean by that. So here's a graphic from a paper Dhruv Kular led that I was on from a couple years back, just trying to outline, make it crystal clear that the marketplace for drugs is a product of public policy. Again, focusing on the US, from left to right in this figure is time. What it shows is the money flowing out and then into the pharmaceutical sector for drugs that are successfully developed. And what I want to emphasize, hopefully you can see my arrow, is there's this initial research period drug companies undertake where they have to spend money to develop a new drug and they can't yet sell it. Then the FDA approves that drug. Again, this is successful drugs only. And begins a monopoly period where only that company can sell that drug and make it, and they can charge whatever they choose for it. That doesn't mean they can charge an infinite sum because there are other forces at play, but they control this price. That during that period, they're getting the bulk of their reward for their innovation. And then there's this thing that, as a technical matter, is a loss of exclusivity. They lose the ability to be the only ones making that drug. And then there are competitive forces that push down the profits to the pharmaceutical company till they get to this tail of essentially cost of production and distribution or market profit. It is the ratio of these things, this area to this area, the factor of time and the probability of success that dictates what drugs get developed. Now, to just re-emphasize this point, every one of these things is a product of policy. The FDA approval standard is not a thing etched in stone. It is written and constantly being modified by government policy. How generic and biosimilar drugs come in after loss of exclusivity is a product of policy. Lauren just showed biosimilars versus biologics, comparing the EU or ex-US to the US, showing that, it's not that the drugs are different, it's that the policies allowing entry are different. How monopolies end, what the rules are for patents, again, purely a product of policy. And this is the one place where we think the market works, but just to be fair here, this is a market working in a completely constrained environment. And to further illustrate, policymakers are constantly tinkering with this. This is what the 21st Century Cures Act did to this box shape. It reduced FDA approval requirements, which means the cost and period of time of negative profits is shortened. It moves up the time of FDA approval, which is favorable because of the time component. And then it allowed promotion of drugs off-label, increasing the amount of reward because increasing the number of patients who get the drug, even in populations in which they're unapproved. Here's the Orphan Drug Act of 1983. It reduced the innovation cost. It shortened the period. It lengthened exclusivity. All things through things like tax credits, all things that shifted the reward towards orphan drugs. And we get what we seek. This is, in a sense, policy working, although not necessarily to our betterment. Here's a chart looking at FDA approval indications from 83 to 2019. Those for orphan indications, these are diseases affecting fewer than 200,000 people, contrasted just against approval for cardiology and vascular disease drugs. Cardiovascular mortality is still the #1 killer in the United States. And you can see in this year, we just get this explosion of orphan drugs. And actually, if anything, flat to a declining relationship for the drugs for diseases that kill the majority of Americans. It's also commonly said that, this is all about innovation, this is all about key breakthroughs. But the reality is, if you look at pipelines, we generally have a very small smattering of true breakthroughs or insights. This is an example of the ALK fusion alteration in lung cancer that was discovered at the beginning of at the end of the 2000s. And then we get one drug that works, and then we get 7 other followers. And this isn't necessarily socially optimal. So here's a list of all of the drugs approved and under development targeting out this ALK alteration. Once we found it, it turned out you could make drugs for it. And these drugs, on the market collectively target 2.6% of all patients with lung cancer. Lung cancer is #1 cancer killer, no doubt, but this is a very small fraction. It's not, please don't think I'm being hard-hearted here. It's not that these patients don't matter. Of course, it's not that benefiting them isn't an important public goal. Of course it is. I'm trying to show the heavy concentration of efforts where the opportunities are that obviously don't scale to important public health impact. This is not new either, that the pharmaceutical industry is breakthrough followed by a rush to the money, right? This is what we saw with benzodiazepines. Valium was the biggest selling drug for, I think, almost 2 decades. Statins, ACE inhibitors, opiates, immunotherapies, CAR T, gene therapy. We get 1 and then we have 7. And in fact, if you look at the breakdown of drug approvals, the percent of total FDA approvals, this light blue beginning of the stacked bar reflects the proportion of drug approvals that are simply follow on similar drugs. And here's an example, again, a disease that is extremely rare called spinal muscular atrophy. Prevalence is about 1 per 100,000. Important, of course, for those who suffer, but I'll give you a very short personal anecdote. I am triple board certified. I'm a pulmonary doc as well as some other as internal medicine and critical care. I had never heard of spinal muscular atrophy until the first drug came on the market for it. And this is all of the drugs that are both on the market and in development. This is not tackling a major public health problem. Again, the patients matter, of course, but this is a disease of 1/14,000th as prevalent as diabetes. And we see nothing like this happening in diabetes therapy. Part of the reason for this is that narrow markets are attractive to companies. And I'll just be totally frank here. If you have a serious illness, there's more pricing power. To flip back a slide, these drugs are hundreds of thousands of dollars. This is actually $2.1 million. It's just easier to get pricing power when you have narrow markets. They're very attractive. It also costs less to, frankly, buy market share. And it costs money to get prescriptions written. You have to go find the doctors and you have to convince them to prescribe your drug. If you can get highly concentrated disease, you can often get highly concentrated providers, which means you can pay them more money and give them other goods and services and more direct contact with drug reps and more lunches, et cetera. And that drives prescribing effectively compared to drugs which would be widely dispersed across large populations. And shown here are examples of prescribing effects related to payments to doctors, and showing here that, for example, how much oncologists are getting paid based on whether or not they are influential or not. These are the oncologist payments for people sitting on cancer guideline committees compared to oncologists who are not. This is the industry at work trying to drive uptake of mostly orphan drug diseases, paying direct payments to people sitting on guidelines that recommend those drugs. And if you ask, I said this is sort of eroding on every margin. One of the things that's clear, shown on the left here, are cancer drug prices. Shown on the right are drug prices for other categories of drugs. And those, you may hear this thing about list price versus prices after rebates or net price. All of these things are net prices, so they are true prices in the market. And you see these rapid rises in prices over time, over decades. And please note the y-axis here is log scale. And so you get this sense that, okay, prices are rising very quickly. So for this to be equally efficient in terms of pricing over time, you'd want benefits of these therapies to rise just as quickly. But you don't get that. And in fact, this is the last broken piece of the market on pricing, as well as the concentration, is this problem that we're in this endless loop. Focusing on the right-hand side of this chart, this is the work from David Howard I was lucky enough to be involved in, but a number of studies have shown this. If you just ask the question, are prices for cancer drugs rising in line with their benefits, or are we actually paying more and more dollars for each unit of health benefit every year? The answer is clearly the latter. Adjusted for inflation and other factors, over this 20-year period on this chart, the cost of a life year, again, pardon for sounding hard-hearted, went up 5-fold. So the drugs are getting less and less efficient in terms of generating health per dollar spent. But more importantly is the left-hand side of this graph. And that's the Red Queen from Alice Through the Looking Glass. The what she's showing is the Red Queen race, the race that you just have to run faster and faster and faster to stay in place. Attendant with this high prices is this very simple argument that falls apart the moment you look at it, which is the industry says you must pay high prices to get companies to invent future treatments we need. But then you also pay high prices when you get that future treatment. A classic example, we finally got a highly effective treatment for hepatitis C. The company chose to charge $1,000 for a pill for it. We're nearly a decade into that pill being available, and the majority of people with hepatitis C have not received it because of its cost. And so that means that you can't get it even though we need it, which is why we were paying high prices in the first case. And you can sort of see where this is going, which is we're not getting what we are paying forward for, because every time we get there, we're just told, oh no, wait, it's the next innovation you need to pay high prices today for, hence the Red Queen race.
Dr. Bach, you have a couple more minutes.
This is my last slide.
Wonderful.
Fantastic. I'll drag this one out. The simple answer here, and as I said, there are many fancy solutions, is to go back to this basic structure. Government policy gives companies monopolies. In all other contexts, we respond to the granting of monopolies with the determination of prices that meet societal goals. There needs to be profits for the industry so they keep doing what they're doing. There need to be reasonable prices so what they create when beneficial is accessible. And I've shown here a card from Monopoly to point out that even industry executives probably played Monopoly when they were younger. And in the game Monopoly, prices are fixed when you get a Monopoly based on how many houses or hotels you have. And this is what we do with monopolies. And it is the only reasonable route to getting a balance between these things, because then we can send price signals to the market for this is of value to society, and so we'll pay a high price. This is of less value to society, doesn't work that well or something like that, we'll pay a lower price. Thank you very much for your attention.
Thank you very much, Doctor. Michael Baylett, are you there?
I am here.
Wonderful. Welcome.
Thank you. Nice to be with everyone this afternoon. Let me pull up my presentation. Whoops. Was there and then it wasn't there. All right, let me try that again. Okay. So I am going to give you some Connecticut specific information today. This is going to be a two-part presentation. I'm going to share what we know about healthcare cost growth in Connecticut's commercial market. And then following my presentation, Marilyn Bartlett will share information on analysis of Connecticut hospital costs that the National Academy of State Health Policy has performed. So we're going to focus, as I said, on cost growth in the commercial market. The Office of Health Strategy employs two data sources to understand healthcare spending patterns in the state. The first is the state's all payer claims database, and the second consists of payer submissions to the Office of Health Strategy in order to assess performance against the state's cost growth benchmark. My presentation today is primarily going to rely upon the APCD analysis, but I want to first share with you the difference between these two data sources. So the benchmark data analysis on the left, I want to describe first. So this is it consists of aggregate information that's submitted by payers in order to assess per capita healthcare spending growth over time and to assess that spending growth relative to the cost growth benchmark established by the state. The aggregate data are used to measure trend at four levels: the provider entity level, insurer level, market level, and statewide. What's missing from this information is a lot of detail that you find in claims, because this is aggregated spending data. The all payer claims database analysis, in contrast, works with granular claims level data. And that information can be used to identify what's driving the broader trends that are identified in the benchmark analysis. It uses the all payer claims database, but doesn't have all of the information that's in the benchmark analysis. Specifically, it's missing most self-insured commercial claims, non-claims-based payments, and drug rebates from drug manufacturers, and finally, insurer administrative costs and profit. So I want to share with you a little bit of information using cost growth benchmark data that gives us a little context of spending pre-pandemic in the commercial market in Connecticut. So this is aggregate data supplied by Medicare, Medicaid, and commercial insurers. On the left, you can see that for 2018 to 2019, spending grew 3.3%. This is both medical expenditures and private insurer administration and profit. But that 3.3% trend looks very different at the market level. So the other bars you see here measure just medical expense, so no insurer admin or profit. The commercial trend at 6.1% was almost double the state trend. The Medicaid trend was actually negative for this 1 year. The reason was primarily because of a drop in long-term care spending. So when we pulled out long-term care spending, you can see that the Medicaid trend was positive at 2%, but that's a third what it was in the commercial market, and equal to what spending was, growth was in the Medicare market, also at about 2%. The absolute levels of spending, you can see, are highly variable here, with Medicare spending much higher on a per capita basis than for commercial or Medicaid. Okay, so this is the type of information that we can understand on spending patterns using what I refer to as the cost growth benchmark data. This is aggregate data from payers. When we use that data to figure out where spending is growing the fastest or was growing the fastest pre-pandemic 2018 to 2019, I want to start again on the left. We've got three primary cost drivers in terms of area of spending: hospital inpatient, hospital outpatient, and retail pharmacy net of rebates. So on a statewide level, pharmacy was growing fastest at 6.8%. But when we look at this by market, it looks very different. In the commercial market, it was hospital inpatient spending that was growing the fastest at over 9%, and pharmacy at only 4.3%. Those percentages are flipped when we get to Medicaid and Medicare, where hospital inpatient is flat or negative, and retail pharmacy growing at very high rates. So as you can see, patterns of spending vary a lot by market. What I'm going to be focusing on the rest of today is on that commercial area, but I want to note that it's also interesting to note different patterns in different markets. So let me move ahead. So why do we focus on the commercial market? Well, because this is where affordability is the greatest problem. We've had the insurance premiums in the state grow 2.5 times faster than personal income over the last couple of decades, and that's not counting the out-of-pocket spending due to higher deductibles. A survey of Connecticut residents earlier this year found about half of Connecticut residents with commercial coverage went without care due to cost in the prior 12 months, and a quarter of them didn't fill a prescription or cut their pills or skip doses. The impact was even worse for people with disability and people of color. The percentage who went without care due to cost, 2/3 of residents in households with a disability, and 57% and 55% respectively of Black and Hispanic residents. So this is a serious access problem and hence quality problem for Connecticut residents. So previously, OHS measured and reported on spending between 2015 and 2019. What did it learn? Hospital and retail pharmacy accounted for 80% of spending growth for that time period. The growth in spending was due to increased payment per service. Utilization actually declined for those services. Brand name drugs were driving retail pharmacy spending, and some hospitals benefited from much higher rates of service unit payment growth than did others. So now we're going to look at more recent data. This is moving forward 2017 through 2021. So we're capturing the impact of the pandemic. Population, as I noted, this is the APCD population. So we don't have the self-insured by and large. And we also don't have non-claims-based payments or pharmacy rebates. So here's what things look like through 2021. The headline spending growth was about 7% per year for this time period. The most recent year, 2021, had a huge rise in spending, 24%. There's a little bit of a V effect. So 2019 to 2020, there was a decline, but the increase 2020 to 2021 was much greater than the decline to 2020. So that rate of increase, 6.9%, that compares to median annual household income growth for Connecticut residents of 2.7% per year. So 2.5 times faster than people's incomes growing. I'll also share anecdotally that the rate of change in 2021 in Connecticut is higher than what we've seen in 2 other New England states. You can see the information here is listed by insurer. I just want to note that the rates of growth vary by insurer, as do the absolute levels. There's no adjustment here to account for differences in member population across these insurers, which certainly existed. So that was medical spending growth. This is pharmacy. Pharmacy, not quite as fast, 4.3%, but still 1.5 times faster than what income growth was. And here's a graphic depiction of that V effect that I talked about. You can see the drop in spending in 2020, and then the huge rise of spending in 2021. The color coding tells us in 2021, it was driven first by hospital outpatient spending and secondarily by professional spending for that 1 year. All right, so a question we often want to ask is are changes in spending due to changes in service utilization or payment rates? I will say that prior to the pandemic, so this is 2015 through 2019, medical and retail spending growth was all driven by payment per service unit, or what I will simplistically refer to as price. When the pandemic hit, things changed. So utilization, which was flat or declining for both medical and retail pharmacy, declined even further in 2020. But then in 2021, rocketed up in medical and increased only modestly for retail pharmacy. So that increase in utilization in 2021 was really unprecedented after years of flat or declining utilization. And so while for 2015 through 2020, we consistently saw price driving medical spending, for 2021, that was not the case. And it remains to be seen whether we're going to revert to what were long-standing patterns in 2022 and beyond. You can see for retail pharmacy, things didn't change a lot. It's been price driving spending growth year over year, consistently, including through the pandemic. If we look specifically at inpatient hospital emergency department, the story is a little different. Utilization did not skyrocket for either of these services in 2021, the way that hospital outpatient did, and average price continued to grow at a high rate for both of those service categories. But here's the hospital outpatient story, and this is really what impacted spending in 2021. You can see that enormous rate of growth in utilization for hospital outpatient. Professional spending, the story here was also an increase in utilization, but nowhere near as sharp as what we saw for hospital outpatient, and in fact, nowhere near as large as the decline that had happened the prior year. And price has grown at a much more measured pace for professional services than for hospital or for pharmacy, and that's a longstanding pattern that we've seen. Okay, little detail on pharmacy. These graphs are a little wacky, especially the one on the left. For retail pharmacy, we saw that in 2020, utilization jumped up. So all other utilization went down, but retail pharmacy for brand went up, and then seems to have reverted to a lower rate of utilization change for 2021. Okay, and conversely, average price dropped in 2020 for retail pharmacy, but then began climbing again in 2021. Generic pharmacy, long-standing patterns of declining utilization and of very modest changes in price over time. All of the spending growth in retail pharmacy has been really in brand. This is an analysis that breaks apart retail pharmacy from what we call medical pharmacy. These are drugs administered by clinicians in hospital outpatient departments or physicians' offices. They're sometimes referred to as Part B drugs. They're sometimes referred to as infusion drugs. What we have seen over time is the percentage of spend that is attributed to medical pharmacy has been growing quite rapidly year over year. You can see here that retail pharmacy spending as a percentage of total spending actually dropped for this 2017 to 2019 period. I don't have more updated data for it, but medical pharmacy growing year over year. And given the price points of the introductions of these new drugs, I would expect this trend to continue. A little more information on pharmacy for the medical pharmacy. The top 10 drugs, only 3.2% of all prescriptions, account for 44% of spending. So the spending and spending growth is highly concentrated in the medical pharmacy market. I'm going to skip this slide. So some key takeaways. Commercial spending growth far exceeds income growth for Connecticut residents, which means that's taking money that would be used for other purposes, obviously. As expected, we saw aberrant utilization and spending patterns in 2020 and 2021 due to the pandemic. Big drop in utilization followed by a much larger rise in 2021. And payment per service generally continue to grow with a couple of exceptions. Okay, Marilyn, I'm going to turn things over to you.
Good afternoon. Hi, everyone. I'm not Marilyn. Sorry,
No.
excuse me. But
Sorry.
Marilyn will be jumping in for the questions and discussion later on, so I'm happy to have her here. I think actually, Alex, or you all on your end have the slides. I don't know if you plan to advance them or if
I can advance them for you.
Okay, thank you. So we're excited to share a different way of looking at hospital costs than you shared, Michael, but equally important, I think, in the context that you shared about how 1 in 2 of Connecticut residents and a number reflected across the country skip or avoid care because they can't afford it. So looking forward to it. Next slide, please. So we'll be sharing some data that we shared with the state earlier this year, really around our break-even analysis and data taken from Medicare cost reports. But next slide, please. A little bit about the data and where it comes from. We do look at Medicare cost reports because they are submitted by hospitals on an individual hospital level annually to the federal government, and they are certified by the hospitals as well. And we take all this data and put it into our hospital cost tool, which is available online and transparent. We show where we take all the cell references from the Medicare cost reports to arrive at the calculations that we're going to show you here today. Next slide, please. So really what we're looking at here, amidst the landscape of rising costs and rising charges, Marilyn Bartlett developed this tool, the hospital cost tool, to kind of disrupt the regular dynamic, the traditional dynamic of paying hospitals, really as a discount off of charge master rates, which can vary and aren't legally required to be based on costs, but rather to provide payments up from costs rather than down from charges. But to do that, we really wanted to take a holistic look at what a hospital's costs are and also what their revenue sources are as well. While the discussion traditionally focuses on patient services, hospitals have many other sources of revenue and expenses be it investment income or cafeterias, parking lots, all these other things. So we take all these expenses and we put it into our number, the commercial break even, which is how much a hospital needs to be reimbursed by commercial payers in order to cover its expenses. And we mean all expenses. So we bring in the commercial patient costs that the payer would have to reimburse and cover. We bring in any potential shortfall from government payers like Medicaid or Medicare. We bring in uncompensated care, charity care, bad debt. We also bring in Medicare disallowed costs. So things like research or those cafeterias and parking lots that I was mentioning earlier. And lastly, we bring in any other income or expenses. So if a hospital had a good year on investments, for instance, we would bring those in to the break-even data point. We'd also bring in federal COVID relief dollars, which are categorized other income. The only thing that we do not include here are physician direct service costs and physician private offices, as those are already reimbursed through other channels, the resource-based relative value scale. So we bring those into our break even. And to compare our break even, which is, again, what a hospital needs to be reimbursed to cover its expenses, we look at the commercial price as evaluated by the RAND Corporation and their studies in aggregate from 2016 to 2018. And coming soon in the next week or so online, we'll also see some updated data for the RAND 4.0 study, which looks at 2018 to 2020, as well as some 2021 Medicare cost report data. And really we do this because we use Medicare as kind of this baseline because they are so comparable, because it is standardized, because it's transparent. Medicare, using that methodology, they already adjust for things across the country like local wage index, which allows us to get a better comparison across states rather than if we were just looking in whole dollar amounts. So next slide, please, Michael. So some factors quickly that impact break even, that green bar that you saw earlier. If a hospital has a high Medicare reimbursement, for instance, if it receives more than 100% of its costs from Medicare, then that break even would be lower. If they receive a payment that exceeds its cost of Medicare, its break even might be lower. If they had significant other income, for instance, a large amount of COVID federal relief, that payment that would be required, that break even might be lower. And so on for other reimbursements from other payers, such as CHIP or Medicare Advantage. And then lastly, something that might impact the break-even calculation are reporting errors. Though the Medicare cost reports are submitted by hospitals and they are required to be certified to their accuracy, sometimes some reporting errors do occur, as is natural, and we do our best to clean that as best as we can without potentially removing anything that could be looking like it's extreme, but it is in fact what was reported accurate in that way. Next slide, please. So a quick example of what break-even and price looks like in Connecticut and surrounding states in the nation. Again, you'll see here, so for instance, in Connecticut, the second to the right bar here, the commercial break-even, the median commercial break-even for Connecticut in 2019 was about 130% of Medicare, and the median price was a little over 200%, meaning hospitals in Connecticut, the median hospital in Connecticut would needed to be paid by commercial payers about 130% to cover their expenses without profit, but they received over 200%. So that spread there you can see. So compared to the other surrounding states, Connecticut has a relatively high break-even, though all the break-evens fall within a range we typically see from 100 to 150% of Medicare. And you'll also see here the prices, nationwide prices, New York prices outpace Connecticut, but later on in the slide deck, we'll break down a little bit more granularly in Connecticut and see, while it looks to be kind of far from New York in some ways, in other ways it's a little bit closer. But next slide, please. And here we see the same data, but just for 2020 to get another updated look. You'll see Connecticut moved a little bit down, Rhode Island moved a little bit up, and New Jersey moved a little bit up in comparison. But still, the prices and break-evens roughly, the break-even, excuse me, is still falling around that 100 to 150% of Medicare range, and the prices above that. Next slide, please. And here, just a year-over-year comparison. I know we just showed both of them, but sometimes the slides changing can get confusing. So put them both on one slide. Here, you'll see Connecticut's break-even. So the expenses of hospitals went up slightly, and on most of these states and comparisons here went up slightly from 2019 to 2020. Next slide, please. So next we looked a little bit more granularly at Connecticut. We wanted to look at the major health systems and what their break-evens were, what their prices were here. So we looked at those systems that have 2 or more hospitals that operate in Connecticut. And here you'll see it ranges from Prospect Medical Holdings all the way up to Western Connecticut Health Network. But one thing we'd note here is the break-evens are increasing, but the prices don't seem to be commensurate with that same break-even rate that you see there. There doesn't really appear to be a correlation. Next slide, please. And the same data, but for 2020, you notice one of the bars went away at the time that we conducted this analysis back in March. Prospects had yet to report their 2020 data, but have since, but it's not included in here. And a relatively similar story, as you'll see. Next slide, please. And again, just comparing the health systems on a 2019 to 2020 basis, you'll see Western Connecticut Health Network, relatively high break-evens compared to some of those other ones. That would note the largest systems, I believe, are Hartford and Yale New Haven in here. And next slide, please. So we wanted to look at those larger systems. The Yale New Haven, first of all, we looked at those counties where Yale New Haven operated a large amount of beds in the state. So here, for instance, in the middle county, you'll see in New Haven County in Connecticut, Yale New Haven Hospital, the landmark hospital, has 1,288 beds, which far surpasses the other beds that are included at the hospitals in that county. And you'll see it has among the highest prices there as well. A similar story, if you look at Fairfield County, Connecticut, you'll see Yale New Haven has combined with this Bridgeport hospitals, this Greenwich hospitals, some of the highest amount of beds in that county. And they all seem to have a pretty high amount of break-even prices. And one thing we'd note that we found there in Fairfield County, which is the county that is closest to the New York metro area, had among the highest break-evens and prices in the state of Connecticut. Next slide, please. And next, we looked at those counties that have a large amount of Hartford beds. And so you'll see, for instance, in the Hartford County, Connecticut, you'll see Hartford at the very far left, the hospital with 702 beds. And you'll see Hartford also in the other counties at Charlotte Hungerford and at Wyndham Hospital. And here we'll note that Hartford, of all the hospitals, all the systems, excuse me, when you look at their hospitals, had the largest spread between the green bar, the red dot, the break-even in price of all the systems that operated in Connecticut at this time, a 91 percentage point difference between the RAND price and the commercial break-even. So what they are being paid versus what they might need to be paid to cover their expenses. And next slide, please. Oh, feel free to just put all of them on the screen. Thank you. So the key takeaways and considerations from the data we just shared. We note that, compared to the surrounding states, the hospitals in Connecticut have relatively high commercial break-even and relatively standard median commercial prices, which we could see suggest the potential for both the commercial prices to be aligned more closely with the break-even, so to bring the red price more in line with that green bar, but also that there might be some inefficiencies that need to be addressed, which could secure lower hospital costs and decrease those break-evens. And secondly, we note that of the major health systems, Hartford, like we said, had the largest spread, a 91 percentage point difference in 2019, a 99 percentage point difference in 2020. And lastly, we'd look at those hospitals that we saw in 2019, given their 2019 expenses in Connecticut. We note that prices between the difference in break-even and price could be lowered at 13 of those 28 hospitals at that 208%, which is the median amount for Connecticut. So thank you. Next slide, please. And that is it from us. I'll turn it back to you. And I'm sure Marilyn looks forward to answering your all's questions when we get to that point. Thank you.
Thank you very much, gentlemen. Most appreciated. Okay, so our last speaker and presentation is Kurt Barwis.
Good afternoon, and thank you for giving me the opportunity to present. Can you post the slides for me, please? Thank you. Let's go right to the second one if possible. So I'm Kurt Barwis. I'm at Bristol. I've been there for 17 years now as the CEO. And in a prior life, I was a CPA auditor of hospitals in the Mid-Atlantic State area. So I audited hospitals. I audited cost reports. I actually did a cost report on a Monroe calculator before we had computers. So and made a mistake in the last page, which cost hours of time. So you know, if you think about the slides you just saw, one of the critical break-even factors is the percentage of government pay. For Bristol Health, it's 72% of our business. There's a slight portion in there that's that goes next, which would be workers' comp, and then a very small portion of our business is commercial pay, which is why that slide that you saw, I think was the last one, shows that we'd have to be getting well over 200% for commercial rates to actually break even. We're actually, if you looked at that slide, we're losing money, which is very clear. But then the other part of the story is our cost, if you look at the RAND information, we're at 15,669 is the price you pay for an inpatient discharge from our hospital. We're sixth from the bottom of the pack and half the cost of if you were to be discharged from one of the other hospitals in the state of Connecticut. And despite the fact that we are on a razor thin margin, we continue to provide care in an excellent way. We're magnet designated. Only 7% of the hospitals in the world are that have that designation. And we're the only hospital in the state of Connecticut that's actually gone for the Baldrige Excellence Awards. We've earned silver twice through the Alliance North group. So as a finance person, and having served as a CFO for 2 years during the pandemic, as well as the CEO, what I can tell you is applying the Baldrige criteria throughout the organization, we lean out everything. And if there's an opportunity to save money, we look for it, we do it, but we do it with one thing in mind, and that's the patient and the outcome. Safety and quality is absolutely the front of all of that. So next slide, please. So the real issue for us, and really a big issue in terms of cost driver for Connecticut, is the fact that of our Medicare population, and you heard Patrick talk a little bit about this, 52% of the eligible enrollees in Connecticut are in Medicare Advantage. Medicare Advantage is really the biggest problem for my hospital. Medicare Advantage across the country increased at a rate of 2%, but when you look at the 2021 to 22 increase in Connecticut was 6%. It actually went up 8.6% between 2019 and 2020. So for us, it's not 52% of our book of business for Medicare. It's actually 60.3% of our book of business, right? And I'm focusing on this because as a finance person, as a person who's actually in the weeds all the time, this is the one thing, the biggest issue as a small community provider that I see as in the way of me actually getting to a break in even performance in Connecticut. I love to have higher commercial rates, but I also would like to point out the fact that it's really not the thing that's making me lose money and potentially not be financially solvent. The other thing I'd point out is, and I get this question all the time, why isn't every hospital in the state of Connecticut complaining about this? That's because Medicare Advantage penetration is not equal in each area of this state. So if you go to Fairfield County, Stanford Hospital, they hardly have any Medicare Advantage. We're getting crushed by Medicare Advantage. So it's a crisis for me and it's nothing for others, right? So that's part of the issue. If you look at traditional Medicare, you saw a slide earlier that said it was 87%. And as Patrick pointed out, it's going lower. Medicare Advantage is supposed to pay at least what Medicare pays, but the truth is they don't. And if you look at the overall cost, what I would say to you is from the point that a patient hits our ER and into our hospital, the amount of resources that goes into managing that patient through the approval process, through the denial process, through even to the end, through the revenue cycle is intense. It's at least twice what it is for any other payer that we work with, including Medicaid, right? So my guess is, and we've tried to look at this 100 different ways, that actually Medicare Advantage patients were actually receiving about 78% of cost. So if you think about how fast it's growing in the state of Connecticut, if you have an adversely impacted hospital or geographic region, and now all of a sudden you're getting paid 10% less than Medicare, it changes the whole dynamic. It changes the break-even dynamic for the hospital. Next slide, please. So I see this as the biggest cost driver. And what I'm going to point out to you and show you and prove to you from the data is that the Medicare Advantage plans are actually shifting the cost back to the hospital, significant cost. Next slide, please. So we filed hundreds of complaints with CMS about the behavior. And the biggest issue, and there are multiple issues, but the biggest issue is that when you go through the process of approval, right, most people think that a prior auth, you hear 14 days, 17 days, or whatever. But in fact, the Medicare regs for Medicare Advantage say they get 1 hour on an emergency admission into the hospital for a transition in care. That's what the regs say. A Medicare Advantage organization is financially responsible for post-stabilization care when the organization does not respond to a request for pre-approval within 1 hour or cannot be contacted. That's what it says. And that covers the point at which the emergency condition happens through to actually stabilizing the condition of the patient and actually improving the condition of the patient. So what that means is you hit the ER, you go for the request, the authorization to get them actually admitted to the hospital. You're supposed to get it in 1 hour. And now if the patient's in the hospital and now needs post-acute, you're supposed to get that authorization in 1 hour as well. If the patient goes to the ER and needs an authorization to go from the ER to a skilled nursing facility, which can happen under Medicare Advantage, but not under traditional Medicare, again, the 1 hour rule applies. This opinion came from CMS Baltimore. The issue was that the MA plans were saying, well, you're contracted. I have a contract with you. So those rules don't apply. The opinion says, sorry, but the rules apply to both contracted MAO plans and non-contracted MAO plans. Next slide, please. Next slide, please. So as a prior auditor, we started a process. We actually said to ourselves, we are going to log and notify every Medicare Advantage plan. The minute we actually submit a request for an authorization, we fax over a piece of paper that says, here's the regs. This is what it says. You have 1 hour. They all laugh. And then when we don't get it in 1 hour, we send another one that says, here's the regs. You didn't send it to us. You didn't give us the authorization. And we log it. And we keep all that documentation. We keep copies of the faxes. We keep everything. So as an auditor, I have a complete audit trail going backwards, complete data for all of these authorizations. And when you look at the data, right, what's interesting and the biggest issue is that the delays in authorization from inpatient to a skilled nursing facility, they average sometimes as much as 3 days, because what happens is there's nobody there on the weekend. So on Friday, if I go for an authorization for a patient, I'm not going to get it till Monday or Tuesday. And then add to that the simple fact that the patient who's being discharged and ready for discharge doesn't need to be in that acute care bed. They don't need to be there, right? So how much do you think I get paid for that? Zero, nothing. I get paid the DRG for the admission, and all that delay gets paid for nothing, not a dime. So if you look at 2021, and I'm going to show you, if you give me the next slide, please. Okay, it's more information. I just tried to provide the legal background and the notice and everything that's in the actual regs for Medicare. Next slide, please. This is the data. So this is 2021, and admittedly, we had less patients in 2021 because of the pandemic. But what you're going to see in here, it goes through each one of the Medicare Advantage plans, 5 in the state of Connecticut. And what you'll see there, those bold numbers are by each plan, how many days we had patients sitting. This is only one part of it. That's the patients that are sitting in acute care bed and waiting for an authorization to go to a skilled nursing facility. 406 days. That is an exact number. That is based on logs and auditable numbers, every part of it, right? 406 days, we got paid nothing for. Next slide, please. So 406 days. And when you adjust for, one of the MAOs had a Florida SNF program, which they've now subsequently ended. If you adjust for the waivers that happened during 2021 for the pandemic, right? So there was a period of time, a short period of time where the commercial insurance company said, we'll waive the authorization process to help patients flow because we were getting backed up with COVID patients. You still come back to a number of 95% of those patients required an authorization. Yet, if you look on the right-hand side, 100% of our authorizations get approved. The reason they get approved is because we don't send for authorizations. We don't submit an authorization that we know isn't an appropriate authorization. So 100% of them get approved. And there's a few exceptions in there, which are where you need a denial in order to qualify for a commercial Husky program. And then there were about 21 out of all those authorizations where we actually had to go peer-to-peer to get the authorization to go through. So a big problem, right? 406, 95%, 100%, we get them because we know what we're doing. We know we don't ask for approval for something that shouldn't be approved. Next slide, please. So here's the reality of this, right? If I use the Medicare cost report and just look at the Medicare cost per diem, it's $500,000 in 2021. Those numbers at the bottom for 20 and 2020 are actually both losses. I lost 7 million in 2020 and 2.2 in 2021. So, but that's probably not a good number, the 525, because it doesn't consider what the real rate would be for that many days. So the observation rate would get me $1 million. That says I had $1 million that I should have gotten for taking care of those patients. But the truth is, during that time period, I was paying $190 an hour for traveler nurses to take care of those patients that shouldn't be there. So I'm going to say, I heard a bunch of presentations today that said there is no cost shift. I'm going to be honest with you and say there is a cost shift. The Medicare Advantage plans are cost shifting back to these hospitals. And it's crushing some of the hospitals in the state of Connecticut. $1 million low side, it would have almost halved my loss in 2021, right? So cost shift from these MAO plans, these national plans, back to hospitals that are crushing them financially. Next slide, please. So what about the patient, right? Patient is the center of the universe. Next slide, please. So everybody knows if you leave a patient in an inpatient bed longer than they need to be, there's tons of medical research on this, it adds risks to the patients. They could risk getting an infection, they could risk having other issues, right? It lengthens the time it takes to fully stabilize, improve, and resolve the patient's conditions. They're not getting post-acute care in an inpatient bed. They're not getting it, right? So these practices really force patients to suffer through periods of ineffective treatment before permitting access to the most appropriate therapy. Factually, these patients didn't receive the care they needed while they were parked unnecessarily in an inpatient bed. And because we had to care for these parked patients, admissions were blocked for new patients arriving into our emergency department. And this was like the worst experience in my entire career. Between December and January of 2022, I had 100 patients in my waiting room. I had patients in every spot in my ER waiting to get into a hospital bed. At one point, I think there was 12 patients that needed a hospital admission. I was standing up against a wall in the ER. I had 10 patients upstairs that didn't need to be there, that were waiting for authorizations. And the reason it was so bad in December was because you had the way the holidays fell and all the insurance companies closed down their authorization process. So that was totally elongated. I was calling other hospital CEOs and begging them to take my patients. That's what it was like. That was 8, 9 o'clock at night. And I had hospitals calling me, asking me if I could take an ICU patient. Bristol Hospital, Little Bristol Hospital, right? I have large systems with hospitals calling me to ask me if I could take a patient. So eventually, through some negotiation, the MAOs then released some of the authorization process, but it was well after it was absolutely necessary. So,
Kurt, a couple more minutes.
yeah, thank you. Next slide. So why? Next slide, please. So A, hospitals, 1, cannot discharge a patient without a safe plan. 2, post-acute facilities will absolutely not take a patient without an authorization. They're not going to get paid. 3, the MAOs get paid a PMPM from the federal government, right? They're being paid to take care of those patients no matter where they are. And they're 100% risk for that care. So I can't bill a patient for the unnecessary days in the acute care. And 5 is really important. Every time I try to negotiate a per diem rate for parking patients in my hospital where I have to provide nurses, food, everything, I can't do it. I'm too small to negotiate. I don't have the size to negotiate and go, and I can't go non-par. 60.3% of my Medicare population is Medicare Advantage. How could I possibly face my community and go non-par? I can't, and they know it. So MAOs, they get free care. They don't pay the hospital for anything when it comes to those patients. They park them there, and they have the financial incentive to do this. Right? Next slide, please. Next slide, please. Oops. So what's interesting about all this, and I've studied all the legal aspects of it, when Congress created Medicare Advantage, they did not give CMS the authority to actually resolve these kind of disputes. So that's why I get an opinion that says, you're right, Kurt, and it just gets ignored. It gets completely ignored. Medicare has no authority to get involved with these payment disputes. And in fact, when you look at all the case law across the country, it's the state's responsibility to resolve those payment disputes. Now, the insurance department has one responsibility with MAOs, and that's to credential them and license them in the state. And they only have one criteria that they can use, and that's solvency to fail them, right? But it's the state that has the responsibility to do this. And you see states across this country now enacting rules and taking action, just recently Pennsylvania and Michigan. And the amazing thing is Congress was right when they did this. They were right. You know why? You have 2 studies. You have the OIG report, you can get them online, September 18 and April 22. They all raise these concerns about the beneficiaries. So Congress said it's going to be too much for Medicare, CMS, to deal with payment issues, contractual issues. So we're going to take that and give it to the states. These are just some simple findings, which really kind of exemplify what I'm saying. 13% in those reports, 13% of prior authorization denials were for service requests that met coverage rules, Medicare coverage rules. That's a base requirement. They can't deny things that would have been covered under Medicare, right? So 13%. If I made mistakes on 13% of my patients, would that be acceptable? No. 18% of payment denials were for claims that met Medicare coverage rules and MAO billing rules, which delayed and prevented payments for services that providers had already delivered. And then most of that had to do with exactly what I said, post-acute facilities. So I'm bringing this to you because it is, as I see it, for much of Connecticut, because of this penetration that we have, a huge cost driver. That cost is being shifted onto the hospitals, the systems in this state. And it's, for me, it's moral injury. I got into this to actually take care of patients and do the right thing. And that's evidenced by the fact that we deliver quality care at one of the lowest prices in the state of Connecticut. It pains me to understand that companies that are reporting billions and billions of dollars of profits would take money from a nonprofit hospital like that. I don't understand it. And I can't even get an attorney in the state of Connecticut that can do litigation that isn't conflicted with one of these companies. So where do I go? What do I do? Something's got to change, because I won't make it for the next 2 years. You saw the last slides that were presented. Unless we do something about this, you got to pay me if you're going to leave your patient in the hospital. That's your delay. That's not my problem. You have full access to my medical records. Why are you doing this to me? Why am I the target like other hospitals where they have high penetration of Medicare Advantage? Thank you.
Thanks so much, Kurt. So now's the time for this panel, if there are questions for each other. If you have any questions, I can't see who's on virtually. I'm assuming the presenters are on, but if you have any questions for each other in this open forum, please do at this time. All right, here, Hearing none. As the moderator, I just have one question for the panelists. Could you, I mean, I think most of you heard my opening remarks regarding how healthcare is just unaffordable in Connecticut. So could each of you provide one action that you would recommend in order to make healthcare affordable for the residents of the state of Connecticut? I'm going to start with you, Kurt.
I think you got mine. I think, listen, we have a lot of confusion over prior auth. Representative Wood is here and she's got a subcommittee actually looking at it. You have federal legislation that's in both the House and Senate, which hopefully will get passed before this Congress ends. I'm not sure that fixes the problem though. And the reason I say that is because the whole other piece of this, which has to do with physicians and hospitals and all of this burden that occurs and the cost of it is left to states to deal with, right? The assumption is that we have a contract, right? So it's a contractual relationship. And so that's your problem. So, my one simple thing that corrects these behaviors is to pass legislation that says, if you park a patient in a hospital, for whatever the reason is, I don't care what the reason is, you're going to pay them fair market value for those days. That's the one solution, because guess what? If they had to do that, all that prior auth stuff would get fixed. You'd have people in those organizations on the weekends that would be there to process those authorizations. So one simple solution is you can't park a patient in a hospital without paying them a reasonable per diem rate for that parking post their episode of care and the end of the DRG.
Thank you, Kurt. Is Lauren still on the line, or Dr. Bach, or Michael Baylett, or Marilyn?
All of us.
Yeah, just in order of the how you named us, maybe just for simplicity here. So maybe not simple in some sense, but if you're trying to look at something to sort of really lower the cost of care, I think at the state level, one of the sort of biggest options available is to create your own public option that is not just for the individual market, but it is available for employers to purchase, and to have that public option plan actually be sort of an active purchaser and basically set rates kind of similar to a Medicare type of plan, and would sort of set rates at some percentage of Medicare, and have that as an option for employers to buy into. I think that is sort of the main way you can kind of tackle some of the hospital prices that are really kind of the core drivers of high prices in Connecticut and across the country, but obviously this will be Connecticut specific.
Thank you.
I'll go next, just because you called on me next. Dealing with pharmaceutical prices in the open market is extraordinarily challenging, but more readily available at the state level is doing something about markups, particularly hospital and doctor office markups. There's a couple of things that could be done. The amount of allowable markup in the state to commercial insurers, for example, could be managed or calculated or estimated or constrained. And likewise, facilities that have mandatory discount, access to mandatory discount programs like 340B, could their ability to mark those drugs up or pass through the savings that those programs provide could be addressed. And it's a remarkable share even today of drugs that pass through those systems in terms of total cost, but it also would remove the profit incentive that's in place today for using more expensive drugs, so that you probably would get, the expectation is you would get a shift, the opposite shift to what Lauren was talking about, to actually lower price drugs because the profits wouldn't be there for the higher priced ones.
Thank you.
My response would, well, first, I want to observe that I think the data that we've seen demonstrates that there's market failure in Connecticut, and that's what accounts for the high rates of price growth in both hospital services and in pharmacy services. I think there are multiple strategies that could be taken to address the market failure, but I think absent state action to address market failure, we shouldn't expect to see any change in the high price patterns that have driven spending growth at multiples of what Connecticut households are seeing in terms of income growth.
Thanks, Michael. Marilyn?
Following- Yes, thank you. Following up on that, I think these are great comments. I would say the move to full transparency on everything, full transparency on 340B. What are the hospitals receiving as 340B savings? Where is it shared with insurance companies, contract pharmacies, right on down the line? Full transparency into following the money through the insurance companies, through the different middlemen. So I think we're started with the hospital price transparency. That needs to be ratcheted up a bit, but I think that we need to kind of find where those pockets of money are. And I think states can move forward to address that.
Thank you again, Marilyn. Anyone else I missed on the line? Okay, thank you all very much. I'm going to look to my colleagues for any questions.
Yeah, question for you, Dr. Bach. Any comments on the use of the TV ads to, increase the uptake of high cost drugs? And what impact do you see that having on the market and the drug spending? Peter, you still there?
Dr. Bach?
I think he may have dropped off. I don't see him on our speaker screen.
Okay.
Thanks, Marilyn.
So I had a question then for Kurt. Obviously, you're seeing this unusually high penetration of Medicare Advantage in your community. Do you attribute that to economic pressures on the families such that they are attracted to the Medicare Advantage, which often has lower, even no premiums compared to Medicare?
Absolutely, Ted. It's a great question. I went into Stop and Shop. It's a great point you're making, and the cashier was telling the bagger about her just switching to Medicare Advantage and how much money she saved on her prescriptions. It was saving her a lot of money, and how like all of a sudden she felt like she could live. And so I felt like that was a teaching moment. And I said, but you do realize that you have limited network, and when you get sick, you're going to have to deal with approvals and authorizations. So if you need physical therapy, instead of getting the 8 you need, they're only going to approve 2, and then there's going to be 2 more and then 2 more. And she looked at me and she said, "You don't know what you're talking about. You're lying." And I just said, I surrender. But yeah, I think that's the point. I think, we have a high concentration of seniors in our service area, and I think they struggle. And you've heard it from many other people. It's really a difficult time. This winter, I worry about people being able to heat their houses and the cost increases that they've all had to incur. So absolutely.
Thank you. This question is for Marilyn or Edney from Nashville. And during your presentation, you were clear to point out that that some hospitals had some hospital organizations, significant differences between their expenses and their revenue, that they were operating with revenue that was significantly higher than their break-even point. We've heard from a couple of hospitals, a couple of smaller independent hospitals here today, that that's not necessarily true for them. Now, is consolidation a driver? What would you consider a driver that would enable organizations to operate at higher, or significantly higher than break-even point? And what would you say to commercial payers and to us as regulators and legislators? How can we help address this problem?
I would definitely say we have seen consolidation and mergers increase the prices, and that's vertical as well as horizontal. And we do trend back 11 years, and we're able to see that during mergers, the prices go up. Costs tend to go up too. So from a state regulator viewpoint, I think it's really important to view those mergers pre and post, whether it's a vertical or a horizontal. Some type of authority over examining those mergers, acquisitions, both vertical and horizontal, is I think really definitely needed from the state level to look at those. From the commercial payer standpoint, especially the state, because you're a large purchaser of healthcare, whether it be your state employee health plan, Medicaid, corrections, you're a large purchaser. So really looking at your data and seeing where you land, maybe what you're paying as a multiple of Medicare compared to what that break-even level is, and then negotiating with the hospitals directly. Again, I would say full transparency would require that in looking at both what your TPA, what your insurance company, and what the hospital charges are. Adney, would you like to add? You've looked a lot at mergers and acquisitions for different states. Would you like to add some comments?
Yeah, I think Marilyn, you hit it pretty squarely on the head. Pre and post review, I think we found helpful around mergers and acquisitions. Additionally, state review that captures healthcare transactions that aren't captured under federal antitrust laws, and then other ways of addressing consolidation, whether it be certain anti-competitive clauses that might exist within the provider and insurer contracts that allow for all or nothing contracting, or that allow for tiering or steering, or these other clauses that we found that they can contribute to these higher prices. But I would echo what Marilyn said. Yes, we would see consolidation as an issue. I think the evidence would show that as well.
Thanks, Ted. Yeah. One question, and this is for Lauren. It goes back to the cost shifting or lack thereof, Lauren, in your presentation. We heard from a couple of hospital CEOs today. I think the numbers are approximately 68% of a dollar is reimbursed on Medicaid, and 88 to 87% for Medicare, and dropping, and for CURT even less than that because of Medicare Advantage. I guess the question is, you've identified that there isn't a real significant cost shift to the commercial market, yet I guess the question I have, without those significantly higher reimbursement rates that the hospitals receive from the commercial carriers in the commercial market, you could conceivably put a number of hospitals in Connecticut out of business. If you forced a hospital to move to 100% of Medicare reimbursement for the commercial market, now their average reimbursement is, I would imagine, well below where it is today. So I don't understand the final conclusion that there is no cost shifting, or maybe I've termed it subsidization, between the commercial market and the government payers. And I'd like you to maybe respond to that.
Sure, happy to. So I think there's sort of two ways to look at this, right? On a sort of static basis, certainly if we just look at the things as they are today, it will appear that the commercial payers are sort of subsidizing, lower Medicare and Medicaid prices. But what the evidence that I was showing is that there is no causal link. It isn't because Medicare and Medicaid pay lower, that is the reason why commercial payers pay high. And that if we all of a sudden just increase Medicare prices and Medicaid prices by 50%, so that all hospitals were making a healthy margin on public payers as well, there's no evidence there's no reason to expect that private prices or employer paid prices would come down as a result. So it's just that there's no connection here, right? I think if you all of a sudden made all commercial payers pay 100% of Medicare tomorrow, that would lead to certainly some hospitals would be underwater at that. A lot of hospitals would be underwater at that point. Right. A big thing would just be, again, costs aren't fixed here, right? What it would lead to is there would be salary reductions in the healthcare sector. Healthcare hospital executives, doctors make pretty healthy salaries in the country, right? Some of that would come down. That may be a good or bad thing. I'm not really trying to take an opinion on that, but that is sort of where you would see some of this. I think the other thing that we noted here, and I think some of the MedPAC evidence, is that the hospitals that do have very high public payer shares generally have lower costs. So they have sort of figured out how to lower their costs such that those hospitals are typically making a positive margin on Medicare patients. So, right. So there are some, like, if you lower your costs enough, there are some hospitals, or a decent chunk of hospitals, that are making money on that. And right, the 13% underwater, right, that's sort of a quirk of the pandemic, when there was actually a boatload of money also shuttled toward providers. But still, right, you're looking at 8% or so, underwater on an average cost basis. The Medicaid one's harder for me because, right, that varies a lot by state. There's also generally a lot of extra money. So you have the fee-for-service payment rates, but typically Medicaid, there's a lot of extra state funding that is flowing to hospitals, such that typically, at least across the country, Medicaid hospital prices look very similar to Medicare prices when you take into account all of the sort of extra payments stuff. So I'm a little skeptical that it actually is, if you take all of that into account. It is lower, but it does vary obviously a little bit by state. But I don't want to, I really not trying to pretend that this would be some, easy fix. If all of a sudden commercial payers were paying 100% of Medicare, that would, it certainly overnight would lead to pretty drastic changes. But the point I'm making really is that there's no causal relationship. And right, if we just all of a sudden made Medicare pay more, there's no reason to expect private payers to, all of a sudden pay a lot less for healthcare and save employers a ton of money.
Yeah, I like to add to Lauren's point that this actually happened in Colorado, where they did a big increase to their Medicaid rates, and it did not slow down at all the rate of growth in their commercial market rates. And Paul, I want to step back to a broader point. We often think naturally that costs are going to inform what rates are, but in fact, rates also inform what costs are. So providers that are able to achieve higher rates will often have higher costs because the higher rates allow them to have higher costs. And so I think we need to think about that cost rate relationship as being a little bit more dynamic.
Lauren, if I could just follow up on that, on what you said earlier in terms of the lowering of commercial reimbursement rates. I understand it somewhat, but let's just take it to the extremes a little bit. You'd mentioned that fixed costs were relatively small. And the way I've always understood it, certainly for a hospital, fixed costs are relatively large, unless, of course, you are going to, as you seem to, include labor, current labor costs in there. And by reducing those costs, you might make it certainly less attractive for medical professionals to come work in Connecticut. You might reduce the quality of care that would be available to Connecticut consumers. How would you respond to this?
Sure. So I do think it is right. So it is possible you will see lower, payments to the professionals working in the hospital if you were to, to reduce the payments that are going to hospitals. We really don't actually have great evidence on. We have pretty much no evidence on what happens actually if you all of a sudden reduced hospital prices significantly, and how would hospitals respond. There's sort of evidence from smaller bore versions of this where, a workers' comp program all of a sudden starts paying a lot less, and we saw it mostly just come down to reduced operating costs. But, I don't think that, certainly I'm not trying to advise or anything, reduce hospital prices by 100% overnight or something along those lines. I do think that would cause that would cause a fair amount of issues that you don't want to be dealing with. It also, I will say, I think your point on the sort of state-specific reductions here is an important one, and sort of the argument for doing this at a national level, that if you're going to sort of say, okay, we're going to sort of put a limit on how much private insurers might pay. And maybe you say, we're not going to we're not going to say private insurers can't pay more than 200% of Medicare, sort of cut off the right tail a little bit of that. That is a little bit easier at the federal level because it doesn't lead to some of these state competition issues where, right, you are trying to attract doctors to work at hospitals from different, obviously have some mobility here. So admittedly, I think it is a little bit easier. The flip side is that also makes it cheaper for Connecticut consumers relative to, what consumers pay is directly related to the prices that hospitals and doctors and drug companies get paid. So, right, there are two sides of that coin. But maybe I'm my DC bias, but I do think there is some attraction to doing things at the federal level because of some of the issues that you, I think, appropriately raise here.
Just another question for Kurt, going back to some of the discussion we were having earlier. I understand that Bristol is heavily weighted toward the public programs, but let's talk for a minute about your commercial patient base. Could you tell us a little bit about how that negotiation goes between a large insurance carrier and an independent hospital? What's your experience of that on an annual basis or every 3 years, whatever the contract length is? Give us a little bit of an overview, it'd be helpful.
Sure. Great question. So I have one contract person that does that, and we do our work to present our costs, and we certainly do present the amount of government business we have as part of that equation. So we do present the fact that we're such a high government pay, we need higher commercial rates to actually offset that, and point out our relative cost position is significantly less than the average, in the state, and half what it is somewhere else. So that is the rationale for getting a higher commercial rate, to say you're paying us a higher rate, but the actual cost, when it comes out, it may not relate to that insurance company, but it's a good bargain, I think, because of the quality that we deliver as well. As a small system, we have zero leverage. There's nothing. And it is literally a, take it or leave it kind of a thing. We go through to go non-par, which I did when I came to Connecticut initially, with a payer, was catastrophic in terms of patient disruption and confusion. So if you go non-par with a commercial payer that also does a Medicare supplemental plan, which isn't impacted, you can't avoid the Medicare supplemental folks from thinking that they can't get their services at your organization, and some of them won't get services. So it's quite complex, Ted, and it's our goal was to try to figure out how to do it in a reasonable way. I could tell you, coming out of this pandemic with all these increases, we've one of the things that we did was we immediately sent letters to all the commercial plans to say our costs went up more than what Pat said in terms of rates for our employees. Our wages went up significantly more than 20% over the last 2 years to be competitive. And I can tell you that, contracts run 2 to 3 years, and nobody came back and said, yeah, we're willing to give you more. And I get it from their side. They've already contracted with employers to pay those rates. So it's complex. And when you're small, the negotiating strategy in terms of leverage is just not there usually.
So did just clarify, Kurt, were you saying that part of not getting the rates as high as you wanted were that they were looking at your low cost structure?
Yeah, low cost structure, so obviously if you negotiate a higher rate, but your cost structure is less, they're actually paying a higher rate than what your low cost structure is, your prices.
So it seems to me like you're almost being punished for your efficiency in a way.
You could say it. I mean, I feel like I'm being punished by Medicare Advantage. Yeah. So yeah. And they're commercial. So yeah, thank you.
Thank you, Kim.
Can I just to the last question that was asked, coming out of Maryland for 7 years, you asked a question about, reducing rates. And so my comment back, having been in an environment where rates were set for every hospital through the HSCRC, which was the governmental, quasi-governmental organization that did it, it was done individually. So it was based on a review of actual costs by hospital and how they compare to the regional averages. And it was done with incredible care. So it scares me when I hear, we'll just cap it or we'll just do this, because obviously I need to be more than 200% to actually break even. So thank you for allowing me to say that.
If I could add one thing to follow up on that, in Montana, which many know the story, we implemented multiple of Medicare payment to all hospitals for all services within Montana. All 60 hospitals were contracted, and they were different rates. So we did look at their cost structures. We looked at their break-even points. We looked at the payer mix. Were they losing 40% on Medicaid, but it was only 9% of their payer mix? We did a lot of analytics on this to come up with what the right rate would be. We had significant savings as a state employee health plan. We were able to return well over 50 million back to the state, because we pulled money out of the system and it went back. We worked with each hospital individually. So I would say that that's something to think about from the state of Connecticut as a purchaser. There are ways to link price, as Adney had mentioned, to cost plus instead of discount off ChargeMaster, and look at a multiple of Medicare. It sure worked for us in Montana. Thank you.
Thank you very much, Marilyn. And hello, Representative Wood. Thank you for coming today. Would you like to provide any comment on our forum today regarding cost drivers?
Hi, thank you for having me. Hi, everyone. My name is Carrie Wood. I'm the state rep from the 29th district serving Rocky Hill and Weathersfield, and I'm
Thanks, Ted. We do have three, and just for the record, Representative Comey was here, Representative Delnicki. I just want to make sure that everybody knows we do have three legislators from the Insurance and Real Estate Committee who will be speaking, and we will begin with you. I would request, and I hate doing this from the people who control my budget, but because of timing, I would request that you keep your comments to 5 minutes each. Representative.
I have a short 50-minute slide, Alex. No, I'm just kidding. I just, in all seriousness, I was appointed co-chair of the Insurance and Real Estate Committee 2 years ago, and it's been a crash course learning all things insurance. And I think a lot of the committee's time is spent on health insurance. So what the committee has been doing is really gathering some, I think, the brightest and best in Connecticut, and having discussions on, lifting up the hood of cost drivers. We've taken a step back on just putting forward legislation and really understanding the costs that go into care. So I think a lot of the stuff that we've been working on regarding certificate of need and prior authorizations and consolidations and private equity role really has been a little bit different than what the committee has done in the past, but I think it's worth the time to go, to dive into that. And you have my commitment going forward that will be a priority in the next year, because we do, when we pass legislation, want to pass something that's effective and that does make the proper change. I will say that we have the best state employees regarding the Department of Insurance, the Office of Health Strategies. I'm looking at Paul. Paul, you cannot retire anytime soon. So, and so I do know that with the state employees we have, with the insurance companies, with the hospital systems and the advocates and everyone in this room, that we have the smartest minds to be at the table to put forward good solutions for change. Lastly, I will just say that I spend my days as a commercial real estate agent. I put in fast food coffee shops and restaurant chains. And at a high level, I think we need to do a better job with our care as human beings and our health. I'm opening all these restaurants because people, want fast food and, coffees that are 1,200 calories, every morning. And they're lining up around the block for that. But how can we do a better job with our youth and our state to really take control of our health and have a better relationship with our doctors, better relationship with our insurers. I think that's a goal I'd like to talk about further as well. Thank you.
Thank you, Representative Wood, and that was really concise. You could have gone for a couple more minutes. Also online, and I think remotely, we have with us Senator Matt Lesser, who is Representative Wood's counterpart. He is the Senate co-chair of the Insurance and Real Estate Committee. Can we get Senator Lesser up, please?
Hello, everybody, and thank you, Commissioner Mays. Thank you to you and the Insurance Department, to the Office of Health Strategy and the Office of Healthcare Advocate, and to all of the presenters. This has been a really interesting conversation. And, you know, I want to just echo a lot of what I heard today, which is that insurance is not affordable in Connecticut. Healthcare is not affordable, and that there's a lot of work that needs to be done. And, you know, I'm hearing really about, you know, 3 areas to focus on. One, you know, as Representative Wood said, we've got to focus on cost drivers. And there are 2 in particular that I'm hearing about, prescription drugs and hospital prices. And so I see a lot of work to be done on prescription drugs, particularly building on the recently passed Federal Inflation Reduction Act, but also important reforms around 340B that we need to be considering. Second, the consolidation, the use of tiering and steering clauses within the hospital industry has reduced competition and created real drivers of healthcare costs that I think we need to address. I look to our smaller systems, and they're well represented on this forum, as being a real tool and asset that the state can use to drive down prices, and look to other states. It was interesting to hear Kurt talk about his experience in Maryland, where they have rate setting as a way to potentially address those issues, and hearing the nuance about how they do that in a way to promote competition and lower prices. And then lastly, I think we have to be honest, and that the insurance industry exists in part to bring down prices, and they have been successful in areas. But we have seen in some sort of discrete areas, real market failure, and specifically with regard to the state's small businesses. We just saw this week one of our key small group insurers pull out of that market, leaving our small businesses without affordable options. And where we don't have the private sector stepping up, it's important that we provide public options to make sure that people have affordable alternatives. And I think if we address the cost drivers, but also make sure that our insurance market is working to provide people with options, you know, we'll be able to bring down prices. This is an exciting time to be in this field, to be addressing, you know, the most critical issue that I think people talk about out there. You know, when I go door to door, it doesn't matter whether you're a Democrat or Republican, more often than not, people talk to me about a healthcare issue, because it's hard to focus on anything else if you haven't been able to get access to the care that you need. So I see a lot of opportunity. I think we're going to be able to do a lot in this coming legislative session.
Thank you, Senator Lesser. Also joining us as the ranking Senate member of the Insurance and Real Estate Committee, Tony Wong. Senator Wong.
Thank you, Commissioner. I hope you can hear me, and thank you, Ted, for hosting this informative forum. Healthcare costs are very complicated, and as one of your panelists said earlier, people buy health insurance with their brain in the pocketbook, but they use it with their heart and emotion. And I appreciate that statement, because that's the challenge we've seen in the committee, and how the cost drivers have really grown in listening to the experts. And we've learned from many of them. And this comes on the heel of the COVID pandemic and our current historical inflation. We certainly have a lot of work to do, and the cost drivers, some of it real, some of it are necessary, but some of it can be adapted. But before I go on, I just wanted to say that the timing of today's forum is a bit frustrating for me, and for many of the residents as well, because it comes months after we approved a double-digit health insurance rate increase by the department. And it now comes days after a major insurer announced it'll be leaving the small group business market, showing the challenges of being able to do business in Connecticut. So as rates continue to go up, and as enrollment and the carriers decide to leave the marketplace, we're at a serious crossroad. And now that it's been said and vented by me, I want to declare that I'm very eager to move forward in the upcoming legislative session for real solutions. And I'm encouraged that this informative session has been great. I've been here since first thing in the morning, listening to the experts. And I'm also encouraged that there is a promise of a follow-up public hearing that will allow for greater public input and an opportunity to engage with legislators and experts to challenge some of the solutions that's been provided here and craft a uniquely Connecticut solution that will contain cost and deliver the same level of care. So bottom line is this: there are a number of issues that I have as a question for that we won't be able to ask today, but I'm looking forward to future issues, the future conversations. One is the issue of cost shifting not only on our hospitals, but insurers, providers, and the other aspect that I want to find out more is the impact of our hospital services consolidation, the loss of our community hospitals, and pricing and services and how they're impacted. Obviously, what's stated by my colleagues in the committee is indeed addressing the prescription drug cost. It's looking at pharmaceuticals, our pharmacy benefit managers, our insurers. I'm extremely concerned about the verticalization of insurers with our PBMs. But also, we want to look at our health insurance companies, look at these rate increases, the loss of choice and quality. And also a subset of that is our long-term care insurance increases that have become unsustainable. So the bottom line is, I do believe that the Senate Republicans have offered a better way in the areas of reinsurance, benchmarking, pharmaceutical pricing reform, primary and preventive care solutions. And we really do need multiple perspectives from all the shareholders, not just Democrat or Republicans or deeply invested special interest, but we need to get input from all the shareholders to have real marketplace solutions. So I'm eager to get started, and I'm grateful to learn from all the experts and the insights that's provided, but I'm very eager to get back to work to have all shareholders get involved in creating solutions. We can't stay with our one way is the best way, but we have to figure out a better way incorporating everybody's input. And I'll lead by thanking the various people I thanked in the beginning. We have one of the best staffs in the country in the insurance department. I wish we could utilize that and use their expertise to craft plans that benefit the shareholders that are the utilizers of healthcare insurance in healthcare in our state. So, Commissioner, thank you for the indulgence of the time, and I'm very eager to get to work.
Thank you, Senator Long, and thank you to Senator Lesser and to Representative Wood. Thank you for being here, for listening, for your input. And I also have to say thank you for graciously agreeing to host this so as many people as possible could be here and could share in this. Today's discussion to me was very informative. It's provided some critically important information on the inner working stuff we don't usually hear, on the inner workings of the healthcare system in relation to pricing, in relation to costs, all of which are driving the concerns and driving the increases in healthcare premiums for consumers. I look forward to continuing the discussion and to exploring next steps. And with that, I will say thank you, and I will turn it over to Kim.
Thank you, Commissioner. I honestly just want to reiterate what he said. We appreciate all the input and the insight today and taking your time to come. I want to thank personally the panel 3 presenters. I don't know if I thanked you when we ended. So wonderful discussion. Thank you for answering the questions, and I look forward to more discussions at the next solution informational forum.
Thanks to everyone. And I do just have a couple of slides I want to share just to solidify some of the lessons that we've learned here together. And I appreciate your taking the time to be with us here today. So Alex, go ahead to the first slide. So we've learned that the US spends more than other high quality healthcare nations. I think that's a pretty solid lesson, pretty non-controversial. Next slide, Alex. we've learned that overall healthcare quality is not necessarily superior to other OECD nations. This doesn't mean that we don't have a wonderful healthcare system. It means there's a lot of wonderful healthcare systems out there to me. But we're not getting, we're paying 2 to 3 times. We're not getting 2 to 3 times the quality is the point. Next slide, Alex. So this is a chart that shows along the horizontal axis, lower to higher healthcare spending. You see the US flag over on the right. You've seen a lot of charts with the US flag over on the right. And then the up and down is health system performance, which includes outcomes. It also includes equity. These are Commonwealth Fund slides. And you see that the US did not fare so well in that particular ranking. So we're not necessarily, again, getting our bang for the buck. Alex, next slide. We've also heard several of the panelists explain that the US does not use more healthcare services than other wealthy nations. That's something that really needs to be learned by even sophisticated people in the healthcare market. People who think that it's utilization, it's overuse, it's fraud, it's defensive medicine. Well, when you look at the number of services we use and pay for, it's not more. And so that's an important lesson from today. Next slide, Alex. This is the money shot, folks. And this is what we've been talking about all day. US healthcare is more expensive because the underlying prices are higher. That's the cause. We can talk about what causes that and what the solutions are. Next slide, please, Alex. And this is the last slide I want to leave you with. And this is a very interesting illustration of private health insurance prices in 8 countries. Also high income countries, also high performing healthcare countries generally. And to explain the chart, you see the US flag over on the right, and then there's a series of red dots that are just a straight line up. That's the US price for the various 17 procedures that are on the left. The top 7 are inpatient procedures like hip replacement and knee replacement. The bottom 7 procedures are outpatient procedures like angiogram and MRI scans. And then I've added a line, the 50% line there. And so the colorful dots, and that's half the reason I want to show this, to have some really colorful confetti-like celebration here at the end. But you see that over to the left of the 50% line, that is less than 50%, is where most of the other countries, capitalist countries, wealthy countries, high quality healthcare countries like the UK, like Switzerland, like Holland, like Australia, most of them for most procedures are paying, this is private health insurance, mind you, so it's not their public programs versus our private health insurance or something like that. This is private health insurance in all these countries paying half the amount. And in some cases, substantially less than half the amount. For folks who are curious, that outlier dot, that gray dot over on the right, that's New Zealand cataract surgery. New Zealand's got some kind of cataract surgery expense problem. I don't know anything about that, but that is what that dot is. So this is the data, and CEOs and legislators. You know, if I had a dime every time somebody said, you know, I'm a data-driven person, I need to see the data. Well, this is the data. And when you take it in terms of the Olympics, you know, Usain Bolt from Jamaica just runs a 10-second 100-yard dash. We're running a 20-second 100-yard dash, right? We're running a 30-second 100-yard dash. So it's a real challenge. And I just want to thank everybody who's here. If you're in the room or you're in the reach of my voice, you're in healthcare. It's hard to realize as a community that we're part of a system that is not making it on the international stage, right? We're not the world's best healthcare system that we all know and want want to get to. So I just want everybody to realize the task before us. And I'm not here to be angry or say this industry or that industry or this CEO or that CEO is making too much money. I'm here to say earn it. Okay, earn it. And what the US is expecting of you is to come forth with reasonable prices that are internationally competitive. To get back to my morning comments, this not only helps our families and our loved ones, and that's what healthcare is all about, but it also gets back to Warren Buffett's comment of medical costs are the tapeworm of American economic competitiveness. and we're hobbling ourselves. We're hobbling our future. And it's not going to be solved overnight. It can't be solved overnight. It took us 40 years to get here. It's going to take us a long time to get out, but I know we can do it because this is America, and we can do what the Japanese can do. We can do what the Germans can do. We can do what the Dutch can do. We can match these people stride for stride. And I'm looking forward over this next session and really over the coming years, because it's not a short-term solution to turn a aircraft carrier around, to working with all of you. And I want to thank you for coming here. We are going to try to set up a solutions-oriented session as soon as we can. And I also hope that perhaps we'll be able to have future sessions like this in the future. We weren't able to get all the experts and panelists that we wanted to, just because the day is too short and the material is very compelling. But it was terrific to hear from the experts that we did, and I want to thank them. So we had some real national experts and of course some of our local luminaries. So it's been terrific, and I just want to thank everybody for that. Any closing comments from anybody else? Please go ahead. But thank you, everybody, for a great day.